actually a senior resident in a medical college in Bihar, and I'm going to present my uh, research topic study on pattern of self management practices in patients of diabetes in rural population in Aligarh. So, the background for self care tells that self care involves all the decisions which individuals and families can take for their own health and also for their own physical and mental well being. So, staying fit, exercising, avoiding any hazardous behavior will all come into self care. So, the middle range theory of self care in chronic illness is a theory which was formed by Tiny Jasma, and it tells us through the diagram we can see that it is an integrated model which talks about self care and its components, which are namely maintenance, monitoring, and management. So, in the arrow shown below, we can see that if we are able to maintain, then we are able to detect our symptoms, interpret them, and respond likely. So, the objectives for the study would be the primary objective is to determine the prevalence of overall self care practice performed by the diabetics in the rural area from where my study has been done. And the secondary objective will talk about the self care management practices in diabetics. So, the methodology was as follows. The study period for which we did this study was 1 year. Study type was a cross sectional study, and the sampling frame included all the cases of diabetes, hypertension, and COPD from the rural field practice area in Aligarh, which is a city in Uttar Pradesh, a city in India. Sampling method and sampling technique were probability proportionate to size was used to determine the sampling frame, including all these three NCDs, and via simple random sampling, we chose the patients of diabetes. Sampling unit and study unit were individual. So, in the whole study, we took 486 patients of NCDs for and we took this sample size from 26% good self care practices prevalence taken from a previous literature. So, at the beginning, we formed a sampling frame from our 6 villages, which are the part of the Rural Health Training Center, Department of Community Medicine, and Jawaharlal Nehru Medical College, Aligarh. And then PPS was used to derive the sample size, out of which 316 patients were enrolled in our study. Further, for selecting the patients of diabetes, we took either those who had diabetes alone or had diabetes with any other comorbidity. So the complete sample size for diabetic patients came out to be 121. The operational definition for those who were included in the study were the people who were above 18 years of age and were already diagnosed to be a patient of diabetes mellitus type 1, type 2, either at the Rural Health Training Center or at any other health facility. The patients who at their time of diagnosis had fasting plasma glucose of more than 126 milligram per deciliter or postprandial blood glucose of 200 milligram per deciliter were enrolled at the time of diagnosis. The materials and methods included the inclusion criteria and the exclusion criteria. Ethical clearance was taken from the institutional ethics committee of our medical college. So, in a few in the coming slides, I'm going to just show the results. So, starting with this diagram, which shows the distribution of study participants based on the number of non communicable diseases per patient. So, for seeing for diabetes, we see that only diabetes was present in 66 individuals. Diabetes, along with hypertension, was present in 51, and along with COPD, was present in only a single patient, while all the three NCDs were present in 3 patients. So, adding all these up for diabetes, we got 121 patients. Am I audible? Am I audible, ma'am?
Yeah, yeah, of course.
Okay, I'll continue. Okay, so 50.4% of participants were showing overall level of self-care practice in diabetic patients as a good level. So, out of 121 patients, good level of self-care practices was seen in around half of them. The uh, tool that we used for the assessment of self care in our study was the Summary Diabetes Self Care Activities SDSCA Self Care Measure. It includes 6 subscales, which are general diet, specific diet, physical activity, exercise, blood sugar testing, foot care, and medication. So, as we can see from the subscales itself, that all the subscales are actually the self care components of a diabetic patient's journey. So, permission to use the scale was also taken from the original distributor through email conversations. And further, with the results, the distribution of participants based on the good level of individual self care subscales. So, for the 6 subscales, the prevalence was seen as blood sugar testing was done in least number of people. 29.8% used to check their blood sugar for 1 to 7 days a week. For diet, it was considerably fine, as it was around 60 to 60 to 62%, more than equal to 3 days per week. People used to perform this activity in their daily routines after asking the questions through them to them through the face-to-face interviews. Physical activity was seen in less than 50% of them. So these criteria are based on the scoring criteria of the SDSCA scale. Foot care and medication were very better than the other ones, were better than the other 4 scales. 92.6% people used to check their feet every day after bathing, but the days per week is not that good for India. It is more than 2.8 days per week. Medication was 83.5% people were taking medicines for 7 days per week. This was the overview of the diabetes self care activities. So, coming to the self care management related results, which is my actual title, the secondary objective. So, if we asked a question related to the management, that if the patients are able to recognize their symptoms, like when are they able to know when their sugar is rising? So, 62% of the people said yes to the answer to the question, and 14.9% could not say anything on that. uh, Next slide says that these are the on the leftmost column we can see the subscales and also the questions related to specific diet self-care practice which were asked. So these specific diet self-care practice, physical activity, medication usage, foot care are part of the self-care management. So the pattern that we observed for self-care management in the diabetic population of our rural field practice area showed that specific diet self-care practice, which is comprised of the 3 questions written below, was performed for how many mean days per week. So I am going to tell the discussion on the basis of the mean days per week. So physical activity was performed for more than 3.56 plus minus 4.28 days per week. Medication usage was a better one. It was seen in it says that the people used to consume medicines for more than 5.47 mean days plus minus 2.42 standard deviation. Foot care was performed for more than 3 days by people. For the specific diet points, we see these 3 questions which talk about servings of fruits and vegetables, or servings of food, red meat or full fat, or and carbohydrates evenly throughout the day. Are they able to space the carbohydrates evenly? So these are the different components which I considered for self-care management. So the conclusion for our research would be that self-care management refers to one's awareness towards his or disease and how she manages the symptoms. The patients were focusing on their overall specific diet for mean more than 3 days, and they were also taking more than 5 servings of fruits for more than 3 days. But most of them were also attending a health facility, which I did not show through the diagram or in the results. Okay, I can not tell that. 46.3% had complications, where only 17.4% had hospital admissions. So, recommendation through the research can be that self-care knowledge should be given to the people suffering from non-communicable diseases by health workers. And in Aligarh, which is Uttar Pradesh, a city in Uttar Pradesh, should focus on health system strengthening, as and also should the community health centers in Aligarh should have a better workup for their NCD clinics. Yeah, thank you.
Thank you, Dr.
Diabetes in women with comorbidities. These are the outlines of my presentation. Diabetes is one of the metabolic disorder characterized by persistent hyperglycemia, and it is a multi-organ chronic disease associated with 10 years of shorter life expectancy due to its associated comorbidities and complications. It is said that primary healthcare, more than 40% of the patients with diabetes will have comorbidities. According to the diabetes cohort studies, it ranges from 70 to 90%. It may be due to insulin secretion or insulin resistance or both. Chronic hyperglycemia in synergy with other metabolic aberrations in patients with diabetes can cause damage to the various organ systems, leading to development of disabling and life-threatening health complications. Most prominent are microvascular as well as macrovascular complications. Type 2 diabetes, it accounts for 90% of all cases of diabetes, most commonly seen with the people aged more than 45 years. Still, it's increasingly seen in adult children, adolescents, and younger adults due to the rising levels of obesity, physical inactivity, as well as energy dense diets. Diabetes is common in older women, means the age more than 65 years or more than 70 years. The prevalence of diabetes is 12.2% among the women worldwide. Comorbidities associated with type 2 diabetes. Comorbidity refers to a condition that co-occurs with another condition with implied reference to an index condition. Traditional complications include microvascular as well as the macrovascular complications. Non-traditional concordant comorbidities share common risk factors and pathophysiological pathways, but have not traditionally been considered part of the type 2 diabetes sequelae, such as liver disease, cancers involving the multiple organ systems, because they are less specific or have a lower magnitude of association with type 2 diabetes compared with the traditional complications. Emerging discordant comorbidities do not at present have a clear etiological link with the type 2 diabetes mellitus, but are found commonly co-occur such as depression, asthma, osteoarthritis, etc. Multimorbidity refers to the co-occurrence of two or more chronic conditions. The difference between the comorbidity and multimorbidity is that the former requires an index condition to contextualize the condition, whereas the latter does not assign or differentiate the importance on any one condition, but considers the overall state of having multiple co-occurring conditions. Patients with the diabetes are more likely to develop the multiple complications compared with the patients without diabetes. These effects in people with the type 2 diabetes mellitus lead to an approximate doubling of risk of myocardial infarctions, especially the 5-fold increased risk of renal failure, more than 10-fold increased risk of amputation and blindness. However, the impact of multiple complications also partly due to declining mortalities because of the increased life expectancy, differing trends in the cause specific mortalities, leading to the diversification in cause of death and complications. The most frequent chronic conditions were obesity, hypertension, dyslipidemia, hypothyroidism, and arthropathy, especially the knee osteoarthritis as well as low back pain. And 51% had multi-morbidities, 32% had only one, and only the more extra chronic conditions in addition to the type 2 diabetes mellitus. Diabetes in woman, how unique she is. Woman is unique as she has to play multiple roles in her lifetime at all stages of her life. Hence, taking care of woman's health by healthcare providers is a prime concern. And who is a woman? Woman, the W means is a wonderful mother, O means the outstanding friend, M means marvelous daughter, and A means adorable sister, and N means nice gift to the men from the God. Woman, she has to play multiple roles in her throughout her life stages, and always she has to bear the multitasking things in her life. Diabetes is the ninth leading cause of death in women globally. According to the IDF Diabetes Atlas, in South Asians, mortality in women with the diabetes stands second highest, and India contributes largest numbers of deaths. The most important risk factor identified for the diabetes epidemic is obesity, along with the genetic susceptibility, because in women's higher levels of GAD antibodies. When it comes to the healthcare of the diabetic woman in India, it finds themselves at a greater disadvantage compared to the men because of gender differences in the social culture, access to the care and medications, follow-up and adherence to the medications, and lifestyle modifications. These all are difficult to follow in the woman's life. Women with diabetes face same joys and problems, but with an added element, they battle a chronic disease with various social and personal challenges every hour of the day. Some special conditions are menarche, menopause, pregnancy, and PCOS. Cardiovascular disease is the most common complication and is more serious among women at a younger age than women without diabetes. Diabetes in women could be worse because the disease can affect both patient and the family, because the woman has got a very prominent role to manage the day-to-day activities in her family. Here are the recent diabetes data from the International Diabetes Federation. Approximately 537 million adults worldwide are living with the diabetes, with a prevalence is 10.5% among adults aged 20 to 79 years. By 2045, the idea projects 783 million adults will be living with the diabetes, representing 46% increase. Men have slightly higher rates of diabetes, that is 9.6%, compared to the women, that is 9%. By 2045, the number of people with diabetes in India expected to increase 134 million. Men and women in India have a similar prevalence of diabetes. Gender difference in diabetes in relation with the incidence. According to the Diabetes Atlas 7th edition, in 2015, prevalence of diabetes in men was 215 million, and in case of females, it was 199. But it is going to reach 328 million in case of males and 313 million by 2040. So as the aging advances, the prevalence of diabetes in both genders will be increasing, and it reaches plateau after the age of 75. And this is the bar chart. What are the risk factors for the type 2 diabetes mellitus in women? Commonly, metabolic syndrome, age, obesity, level of physical activity, and polycystic ovary syndrome, history of gestational diabetes. It is the increasing nowadays. According to some studies, it reaches to the more than 26% of the women, they are prone to the GDM in pregnancies, and genetic predisposition. These are the factors influencing the prevalence of metabolic syndrome. Abdominal obesity, waist circumference more than 80 centimeter in women, so which strongly correlate with the C-reactive protein, fibrinogen levels, inflammatory markers, and cytokine levels, appears to predict future development of impaired glucose tolerance and vascular events. There is a higher prevalence of metabolic syndrome in women than in case of men, 45% versus 25%. According to the recent studies, prevalence of metabolic syndrome in the premenopausal is 19.2, in case of postmenopausal 32.4%. There is a strong relation between metabolic syndrome and depression, particularly in women with 70% prevalence. And this is the diagram which depicts the long and short-term metabolic consequences in the gestational weight gain and postpartum weight retention in reproductive age. So in her first pregnancy, the woman will be start gaining the weight that is called gestational weight gain, which will cause the increased BMI, increased fat mass, and increased visceral fat. And in the second pregnancy, this gestational weight gain, it will again still more increases. So because of that, she is prone to develop the metabolic consequences, mainly the GDM, preeclampsia, and hypercholesterolemia. In the later part of her life, again the gestational weight gain, it is going to persist. So there is a increase in the BMI, increase in the visceral fat, and in a later life, the woman is prone to develop the type 2 diabetes mellitus, coronary heart disease, as well as the metabolic risk for the metabolic syndrome. Regarding the incidence of obesity in women with type 2 diabetes, the IDF highlights the obesity is responsible for around 43% of all type 2 diabetes cases, rising to 80 to 85% in some populations. Obesity is a risk factor of critical importance because it contributes the development of type 2 diabetes and is independent risk factor for the cardiovascular disease. In some studies, especially the Framingham study, so where they have found out the women and men, they have included in their studies, and they have concluded that obesity was a significant predictor of cardiovascular disease throughout the 26 years of follow-up of their studies. In the nurses study, they have found out that women had 3 times greater risk of coronary heart disease than lean women. And women who had a significant gestational weight gain had a further increase in the coronary heart disease. Obesity in women and risk of type 2 diabetes. So in the nurses study, again, they have found out that being overweight or obese was the single most important predictor of diabetes mellitus. So a recent meta-analysis noted that strongest association between the bone marrow, this body mass index, and the incidence of type 2 diabetes in case of females. So diabeticity means is defined as a form of diabetes increasingly develops in later life with associated obesity. So physical inactivity in women. Levels of physical activity have been reported to be lower in Indian population as compared to the general populations. So in one study, they have found out that more than 18.4% in India were found to be physically inactive compared to the men, that's 12.7%. So physical inactivity, it causes 6 to 10% of the major the non-communicable diseases of as well as the coronary heart disease, type 2 diabetes, breast and colonic cancers. So polycystic ovary syndrome, it is a cousin of the diabetes. So polycystic ovary syndrome, according to some studies, it ranges for 5 to 26% of the women between the late adolescence and menopause age. It is one of the most common hormonal related problems in women during their reproductive years and is a leading cause of infertility. So this slide shows the effects of PCOS. It is continued starting from the pregnancy. Mainly it causes the PIH as well as the GDM. In the later part of their disease, they are prone to develop the coronary artery disease, type 2 diabetes mellitus, and the metabolic disorders. And in their postmenopausal age, the women, they are prone to develop the various types of cancers. So impact of diabetes on women's health through the life stages of women. In the adolescent years, reproductive years, middle as well as the older years. According to some studies, it was conducted long back. There's a Pima Indians population. Type 2 diabetes among girls, it is increased from 7.2 during 1967 to in 1996, it has reached 27.3 in 1,000 populations. In the adolescent years, there are so many causes which are impact the diabetes. So mainly the psychological changes, physical changes during the adolescence may make it more difficult to control the diabetes regardless of the level of adherence to their diabetes care regimen because of fluctuations in the blood glucose levels, fluctuations in the hormone levels, as well as high estrogen levels and increase in insulin resistance during this period. So many women find their blood sugar tends to be high. That is especially 3 to 5 days before, during, and after their periods. So it is one of the challenge to control the sugar level in the adolescents, girls especially. So premenstrual symptoms can be worsened by the poor blood glucose control. Impact of diabetes on health status. Mainly the complications, especially in the type 1 diabetes mellitus, they are prone to develop the complications, especially the hypoglycemia in 30% of the individuals, and hypoglycemia, especially in the case of adolescents boys, it is a 26%. So chronic complications like diabetic retinopathy is more common in adolescent boys as well as the girls, and similarly the diabetic kidney disease. Adherence to diabetes management tasks. So mismanagement of blood glucose monitoring and exercise as well as the inappropriate food intake is more common in adolescents, especially the 80% of the adolescents. So eating disorders is also very important in the adolescence age group. Mainly the two eating disorders are anorexia nervosa as well as the bulimias. So unfortunately, the prognosis remains guarded for diabetic adolescents with the anorexia and or bulimias. So psychiatric disorders in teenage girls, especially, they are going to suffer from bipolar disease, especially the maniac depression and panic attacks. So mania diagnosis may be delayed until the behavior is dangerous to the adolescent or others. So panic attacks are also very common in case of the adolescents age group. So sometimes the panic attacks will they will be considering it as a hypoglycemic episodes. So unless the frequent checking of the blood sugar, it is difficult to diagnose the anxiety disorder as well as the maniac episodes. So in the reproductive years, for women with the diabetes, this is the time of greatest personal growth and responsibilities. So diabetes in pregnancy, especially the GDM, PCOD may make diabetes management more difficult and they are prone to develop the infertility. And because of the GDM, it has got its own complications in mother as well as the in case of the fetus. So diabetes mellitus should be considered in the differential diagnosis of menstrual irregularities, especially the oligomenorrhea and secondary amenorrhea and infertility. The reproductive period of diabetic woman may be reduced. According to some studies, it is a 5 to 10 years. So better glycemic control and prevention of diabetic complications is very, very important in those age group. Just as with the men, female sexual dysfunction can result from physiological, hormonal, neurogenic, or psychological causes, or a mix of the all the three. So in the middle years, they are more prone to get the diabetes mellitus, and they're more prone to develop the carcinomas of various multiple organs. And along with that, they are going to develop they are prone to develop the metabolic syndromes. So because of that, there is a need of frequent hospitalization as well as the death rates are 3 times more common in this age group in women with a diabetes compared to the non-diabetic woman. So ischemic heart disease is reported to account for 40% of all the deaths. So as woman progresses, 1/3 of her life will be in the menopausal stage. So there appears to be a greater loss of physical activity, which contributes to the weight gain, insulin resistance, hypertension, loss of ovarian estrogen, which leads to the abdominal obesity and increased CAD risk. So women with the diabetes present with so many common symptoms. Among that, recurrent urinary tract infection is very, very common. Pruritus vulvae is very, very common. And generalized fatigue as well as the sleep problems. Women had low self-efficacy with respect to their diabetes care. 35% in comparison to the men, that is 65%. So these are the comorbidities. Among that, dyslipidemia, hypertension, thyroid disorders, and hypovitaminosis D, osteoporosis, and psychological as well as emotional stress. So cardiovascular this one cardiovascular system, it is one of the major macrovascular disease. So already explained this one. And hypertension prevalence depends on the diabetes type as well as the age and BMI and ethnicity. So patients in the BP blood pressure of more than 120/80 should be advised only the lifestyle modifications. When the blood pressure is more than 140/80, they will need along with the lifestyle modification, they need the pharmacotherapy. And patients who has already developed the CKDs, the very strict control of the blood pressure, that is the less than 120/80 or equal to 120/80 is very, very important. So neuropathy, early recognition and management is important because diabetic neuropathy is a diagnosis of exclusion. So because there are so many other B complex deficiencies, especially in case of women, okay, who are all nutritionally not taking care of themselves, so nutritionally malnourished, so vitamin B12 deficiency, and along with that, so many diabetic patients they'll be having the metformin therapy. So even metformin therapy is also going to cause the vitamin B12 deficiency in the long-standing conditions. So neuropathy should be always analyzed and look for very clearly in their every visit to the hospital. So up to 50% of the diabetic peripheral neuropathy may be asymptomatic. So recognition and treatment may improve the symptoms, reduce sequelae, and improve the quality of the life. So according to the epidemiological studies have demonstrated that vitamin D deficiency closely related to the obesity. So especially the waist circumference more than 80 centimeter, BMI is more than 23. So an increased risk of type 2 diabetes mellitus. So a cross-sectional observation study was done in our own tertiary care center. So we have taken 156 females, the age of 30 to 60 years. So the type 2 diabetes, it was accounting for 92%, who were 92% were overweight or obese, and 85% had the BMI more than 23 kg, and 94% were having the vitamin D deficiencies. And we have also observed that as the HbA1c is increasing, so the patients will be having the level of the vitamin D will be also goes on decreasing. So in a study, we conclude that obesity and type 2 diabetes mellitus is responsible for the vitamin D deficiencies. So vitamin D is very, very important. So it will cause the increased insulin sensitivity as the increased insulin secretions. A cross-sectional observation study was done in women with the type 2 diabetes mellitus with comorbidities in our tertiary care center. So we have included 96 female patients with type 2 diabetes mellitus above the age of 30 years and observed that who will be having the comorbidities. So 62 patients were above the age of 50 years and 34 patients were below the age of 50 years. So our study concludes that 67% of the were having the hypertension, 13 patients were having hypothyroidism, 11 patients had dyslipidemia, and 14 patients had NAFLD. 18 patients were without any comorbidities. So it is observed that type 2 diabetes mellitus is most commonly associated with the hypertension as the comorbidities. As the age advances, risk to the comorbidities also increases. We also observed that 59 patients with only one comorbidity, 15 patients with two comorbidities, and 2 patients had 3, and another 2 patients had all comorbidities. The studies have recorded high prevalence of thyroid disorders in the 13.4 diabetic populations, with a higher prevalence is 31.4 among the female with the type 2 diabetes mellitus than males, where they are only 6.9%. So evidence also suggests that strong underlying relationship exists between the thyroid diseases and diabetes mellitus. Researchers have shown that thyroid hormone plays an important role in controlling the glucose metabolism and pancreatic function, while the diabetes can alter the thyroid function. So regarding coming to the emotional issues in case of females, women felt less confident, less supported by their spouses when it come to their care. Women felt more hassled by the spouses. Women had more lapses in self-care and lower quality of life. This was low for eating most of all the things because she has to serve all the family members, and the remaining things sometimes she has to, or sometimes she can fast so many days also. Women were more apt to say that they had sadness or anxieties. Coming to the complications, acute complications and chronic complications. In the acute complications, mainly the hyperglycemic, hyperosmolar coma in type 2 diabetes mellitus, and hypoglycemia needs an emergency care. And chronic complications, already I told, micro and macrovascular complications. And coming to the chronic kidney disease is also worse for the woman than men. Studies have shown that lower estrogen levels are associated with the kidney disease. Coming to the management, investigations to be done related to the associated complications, comorbidities, along with the routine parameters. Treatment includes mainly the lifestyle modifications and strict control of the blood sugars. Treatment of comorbid illness is also very, very important, especially the hypertension control and dyslipidemia, statin signs, antiplatelets, antipsychotic medications, and treatment of the complications, especially the diabetic, micro and macrovascular complication. And sometimes patients may need, whenever they'll be having the diabetic foot, especially when they'll be having the complications, the non-healing ulcers, or patient will be having the gangrenous changes, or severe peripheral arterial diseases, patient has to undergo the amputations. And more than 50% of the cases of amputations are related to the diabetic foot. Treatment of the depression. Proper
Dr. Mamta, please find up.
Yes,
Dr.
only 2
Mamta,
minutes.
please
Yes.
wind up.
Yeah. Management includes the multidisciplinary approach, increasing recognition of the importance of the patient in the medical decision making has led to the 22 consensus recommending patient-centered approach is very, very important. The individualization in the management of diabetes is based on the assessment and addresses the personal issues. The age-associated factors affect the diabetes management in older women, especially because of sensory changes, difficulties in the food preparations, and effects on other chronic diseases. These all contribute for the management of diabetes is very difficult in older women. And prevention. So commonly again the same thing. We have to stick to our diet and regular physical activities. Coming to the summary and conclusion, prevalence of diabetes is increasing in women, which is the ninth leading cause of death globally. Most important risk factors are obesity, physical inactivity, and genetic susceptibility, along with the GDM. Some special conditions are, special already I mentioned, women with overweight and obesity are more prone to develop the diabetes. Death rates for women aged 25 to 44 years with diabetes are more than 3 times the rate of the woman without diabetes. Diabetes in women increases the risk of, already told, coronary heart disease, stroke, and other events. Lack of healthcare, social and cultural disparity, access and adherence to the medications, lifestyle modifications are rarely followed by the woman. Indian women with the diabetes have an average life of 10 years shorter than the woman without diabetes. Being a woman who has diabetes can pose a challenge, but with little help, she can meet the challenges. These are my references. Thank you for your patience hearing. If any questions, I'm happy to answer.
Thank you.
Primordial prevention of diabetes. Am I audible?
Yeah, of course.
Yeah, the slide is not moving. Just a second. The estimations and projections of the number of people between age of 20 and 79 years with the diabetes in different editions in millions. Sorry, there is some problem with the in 2019, it was 463 million. In 2021, it has increased to 537 million, that is a 16% increase. And it will be in 2045, a 54% increase. So, which was 573 has gone to 783. Okay. So the pre-diabetes, apart from this, we have pre-diabetes approximately 318 million, which is likely to increase to about 481 million by 2040. So diabetes is an epidemic of unprecedented magnitude. It was told by Professor Andrew Wilton. And what is in practice to prevent this diabetes? We don't have So what is we have in practice is diabetes mellitus awareness, and we are doing the detection camp. So the detection of diabetes does not mean prevention of diabetes. What we need is primordial prevention of diabetes, that is the disease should not develop. So what steps can we take for the primordial prevention of diabetes? With the diabetes prevention program, what we have is in September 2001, the Center for Disease Control and Prevention, CDC, issued a press note saying that twin epidemics of diabetes and obesity continue to threaten the health of the Americans, and diabetes prevention programs was introduced then. In 2001, the incidence of diabetes was 6.1% of the US population that has been diagnosed. And currently in 2021, 10.5% of the Americans, they do have a diabetes. So obviously this is not a successful program. So then what could be the successful program? Is it possible to achieve a diabetes-free generation? Then when we want that, whom we have to focus. So the female gender is key for the diabetes prevention. led by Lizzie Kingo. This is due to the body's susceptibility to lifestyle diseases which are programmed in intrauterine. That is the intrauterine programming, David Barker's thesis, which can lead to the developmental origin of health and disease. So there are genes. The phenotype of the individual is influenced by first the intrauterine environment and then the postnatal environment. So there is a genetic predisposition. So the epigenetics and the genetics, they act. So we used to say genetics loads the gun and environment triggers it off. This is in this, the intrauterine environment is very important. So diabetes mellitus, whether it is because of the intrauterine environment or it is an inherited destiny, that is the genetics. So when you look into that, to know that, let us look into the developmental origin. The ovum is well supplied with mitochondria, but the sperm contains a few, and even those few do not persist in the offspring. At fertilization, it is only the nucleus of the spermatozoa that enters the ovum, and thus all the cytoplasm, the mitochondria, and the mitochondrial DNA, they are exclusively maternally inherited. So next is the intrauterine environment. Gestational programming is a process whereby stimuli or stresses that occur at the critical or sensitive period of fetal development permanently change the structure, physiology, and metabolism, predisposing the individuals to disease in adult life. This is the Barker's hypothesis. Then this says that fetal origin of the adult disease. So, what are the evidences we have? We have an animal experiment where the Vista rat with a low genetic risk of diabetes, when exposed to the hyperglycemia media of the goat rat, utero, significantly it increased the risk of diabetes in adult life. So the intrauterine environment influences. And what happens in the human beings, maternal hyperglycemia and the progeny, the offerings of the Pima Indians who were in utero when the mother had gestational diabetes mellitus, they have a greater risk of developing diabetes than the earlier siblings born before the mother developed GDM. This is the evidence, the human evidence. So the intrauterine milieu is greater than inherited destiny. So hyperglycemia in pregnancy, that is the GDM, is the intrauterine environment. What happens? The effect of hyperglycemia in pregnancy occurs with gestational diabetes mellitus. They are at increased risk of future diabetes, predominantly type 2 diabetes, as are their children. So both the mother and the child, they are predisposed to type 2 DM later. So this is the transgenerational transmission occurs. And insulin resistance, an increased atherogenic lipid profile, inflammatory markers, hypertension, and endothelial dysfunction, they all lead to the increased risk of the coronary vascular disease. So, GDM is the mother of non-communicable diseases, NCD. The father of GDM in India, Professor Seshia has told, GDM is the mother of non-communicable diseases. So what is the prevalence of GDM? If you see this world over, it is 15.2%, and the number of live births affected in millions is 21.1. Okay, in the different countries you have the prevalence. Southeast Asia, if you look at the prevalence, it is 28%. And the live births affected in millions, 6.8. So the GDM prevalence in Asian countries range is widely from 1.2 to 4.9%, largely accounting for differences in the diagnostic criteria, the sample size, and the population source. Example, hospital-based and community-based. Overall prevalence of GDM in India is estimated to be around 13%. However, the prevalence varies by region, with rural areas having a prevalence of 6 to 9% and urban areas having prevalence of 12 to 21%. What are the implications because of this? Detection of GDM is possible by varied diagnostic criteria, and prediction is at which week we have to screen the patient for the prediction of GDM, and the glycemic level, which is the response for development of GDM. So these two factors we should know. So prevention it is a measure to avoid the development of GDM and its consequences. So this leads on to diagnostic criteria used in various studies estimating the gestational diabetes. If you look at the ADA, we have a DIPSI criteria in India, WHO, IAD-PSD. So different countries, they have different guidelines for the diagnosis of gestational diabetes. And even the same country has two guidelines, which led to the confusion among healthcare professionals. So these criteria, these diagnostic criteria are useless. So therefore, the physiological glycemic level in normal pregnancy has to be recognized and implemented. So pattern of glycemia in normal pregnancy, what is it? How is it? Okay. See, if you look at this graph, the fasting blood sugar is 71.8 plus 71 plus or minus 8, and the 1 hour PP blood sugar is 109 plus or minus 13, and at 2 hours it is 99 plus or minus 10, that is around 110. So if you add 1 plus the plus 1 ST, the 1 hour value should be less than 122 and 2 hour value should be less than 110. Any value above the normal is abnormal. This graph, how it was got. Hernandez has done a meta-analysis of 48 papers, and he has come out with this, the glycemic pattern. So next, look into the embryology of the beta cell development. Each islet cell functions as an endocrine organ. In human pancreas, it begins to develop at 4 weeks after conception, and first insulin deposit can be found between the weeks 7 and 8. And pancreatic islet cells differentiate between 10 and 11 weeks of gestation. And they recognize and respond to the maternal glycemia at 11th week of gestation. So the glycemic level at gestational week for prediction of GDM. We will arrive at the glycemic level at which gestational weeks. First time in NIH study in 2018, they suggested hemoglobin A1C of 5.3, that is the 2 hour PP blood sugar more than 110 milligram at the 10th week predicts the GDM. Hence, for prevention of blood glucose has to be brought to less than 110 as fetal beta cells start secreting insulin around the 11th week. So the blood sugar should be less than 110 milligram before the 11th week. But so far, no explanation has been given for the prediction as well as for the prevention of GDM. The conceptualization of based on the endocrinology and embryology, the maternal 2 hour PP blood sugar should not cross more than 110 at 10th week as fetal beta cells start secreting insulin around the 11th week of pregnancy. When there is a maternal hyperglycemia that is more than 110, there is a fetal hyperinsulinism. So then the concept of fetal glucose steal, which is an underappreciated phenomena in the diabetic pregnancy. See, the glucose from the mother side enters through the placenta to the fetus, causing increased insulin secretion, and the increased glucose is being utilized and results in adiposity. And the mother pushes the glucose to the fetus, and the fetus pulls the glucose because of the gradient. So the fetal glucose state, this is known as the fetal glucose state. The fetus starts utilizing the maternal glucose across the placenta. Hence, maternal hyperglycemia and fetal hyperinsulinemia, they promote the fetal adiposity and results in the macrosomia in the offspring. So if it is a male fetus, later on, that is, it results in the childhood obesity and impaired glucose tolerance at an early age and diabetes in the early age in the adult life. If it is a female baby, it results in the childhood obesity, and when she becomes pregnant, GDM occurs, and later diabetes occurs. So this explains how the glucose steal occurs. So fetal handling of, this is known as actually fetal handling of maternal glucose. At 10th week, this is an example. At 10th week, if the blood sugar is 126, so at 11th week, the baby is exposed to the 126 milligram. This causes secretion of the fetal insulin, and it brings down the maternal glucose, which is not desirable. So subsequently, when you check up, that is at 12 weeks, if you do the blood sugar, it will be 112, which is a normal. Okay. So this effect is not desirable. So the PP blood sugar comes down without any intervention. How it comes down? It is the maternal glucose does not go up due to the fetal insulin handling of the maternal glucose. I hope it is understood. So when the maternal glycemia starts increasing at the 10th week, fetal insulin starts secreting at the 11th week, which is irreversible. So guidelines to see in the glucose intolerance at appropriate gestational week. So at week 10, the PP blood sugar should not be more than 110. When it is more than 110, fetal insulin secretion starts and continues. And this usually, normally, the screening is done around 24 to 28 weeks. The glycemic control needs to be optimized very early in pregnancy to prevent the establishment of fetal hyperinsulinemia. So from the present studies, it is recommended to test for glucose intolerance in the early weeks of pregnancy, which is known as early gestational glucose intolerance, EGGI. The ideal test for the glucose intolerance is at 2 months of pregnancy. Why? Because prediction of GDM is 2 hour PP blood sugar more than 110 at 10th week. Hence, at the 8th week itself, the 2 hour PP blood sugar has to be estimated if less than 110, followed by monitoring the CBG at the 10th week. In case 2 hour PP blood sugar is more than 110 milligram and less than 119 milligram at the 8th week, there will be a grace period of 2 weeks to attain the 2 hour PP blood sugar less than 110 at the 10th week with MNT and metformin. For example, if there is an exam in March, we have to start preparing from the December, January itself to prepare us for the exam. The same way, when you want to keep the blood sugar less than 110 at 10th week, you have to start preparing at the 8th week itself. So these are the references. So early, what is early gestational glucose intolerance and its intervention. Intervention with MNT and metformin should be started. So at 10th week, it will be less than 110. Your aim is to bring it less than 110. So you have a grace period of 2 weeks. So by 11th week, the blood sugar will remain less than 110. So there is no increase in the fetal beta cell insulin secretion, and the following weeks also should be less than 110. So if you are going to detect it at 11th week, there is no enough time is available to achieve the blood sugar to be less than 110. Because the fetal beta cell will start secreting more insulin. This picture should show you the organogenesis. Most of the organogenesis is over by 8 weeks. That is at the embryonic stage itself. So this is the development. Okay. So if blood sugar is more than 110 milligram, MNT and metformin dosage is 250 milligram twice daily, has to be started and continued throughout pregnancy so that the target glycemia will be obtained, and the 2-hour PP blood sugar should be between 99 plus or minus 10 milligram. So, and it has been also found that metformin is safe as embryonic stage is over by the 8th week. And metformin is safe for use throughout pregnancy. The various organizations have said the glucophage metformin was approved as the first oral anti-diabetic medication to be used safely from conception to birth. This is a reference from the SIGO and also BMJ. Okay, so then the safety of metformin is again told by the other organization. Metformin used in pregnancy did not show any adverse effects compared with insulin on long-term outcome in the children. So this is a paper we have published, Prediction and Prevention of Gestational Diabetes and its sequelae by administering metformin in the early weeks of pregnancy. Prevention of gestational diabetes mellitus by treating the postprandial blood glucose more than 110 in the first trimester. The study was done in the Lady Harding Medical College in New Delhi, where the group A, the non-metformin group, 123 women were enrolled who had 2 people have missed abortion, 4 last for follow-up, 117 following till update. Okay, and out of this 117, 99 developed GDM, that is 84.6% they developed GDM. In the group B, the first one is a non-metformin group. In the group B, where we have given a metformin, 125 women enrolled. In this, 3 had missed abortion, 3 lost for follow-up, 119 were following up till date, and this 2, that is 1.6% only developed GDM. So when metformin was given, the incidence of GDM was 1.6%. Without metformin, the incidence of GDM was 84.6%. So the results so far indicate that tablet metformin 250 milligram price significantly prevents the development of GDM in women with 2-hour PP blood glucose more than 110 milligram at 8 to 9 weeks. So this has been published, the correlation between the first trimester 2-hour postprandial blood glucose greater than 110 milligram for prediction of gestational diabetes mellitus with hemoglobin A1C. So the conclusion of the study was PP blood sugar when more than 110 milligram at 2 hours, they exhibit high levels of diagnostic accuracy for prediction of GDM, and is associated blood glucose is a superior physiologic and low cost option compared to hemoglobin A1C for early prediction of GDM. It can also be performed as a simple point of care test with a glucometer at home or in the periphery by healthcare workers. So, what is the status of the hemoglobin A1C? WHO guideline does not include hemoglobin A1C as a means of diagnosing diabetes in pregnant women and for monitoring. So, the use of glucometer, standardized acute glucometer for measuring plasma glucose is found to be good. Prevention of gestational diabetes mellitus by treating the postprandial blood glucose 2 hours more than 110. Another study conducted at Chennai, where the group A is a non-metformin group. 82 women enrolled. That is, the non-metformin is, here the blood sugar is less than 110. Okay. So there in one patient out of the 82, they developed GDM. Because maybe she is a grand multipara. She is a sixth gravida. In group B, metformin was used when the PP blood sugar was more than 110. The first group, the PP blood sugar was less than 110. So in that, only 1% developed a GDM. When the PP blood sugar was more than 110, among the 69 women enrolled, again, one patient only developed GDM 1.4% because she discontinued. One woman 1.4% developed GDM, and that too because she discontinued metformin after 6 months of gestation. This clearly shows that there is a great scope for the prevention of GDM and the NCD. This has been published in InTech Open Access. So this is the mean glycemic.
Dakshi, please try to wind up.
Okay. A few more slides. Okay. By 11th week, the intervention group continued to show lower glucose level, demonstrating the effectiveness of early intervention in maintaining glycemic control and thus prevented the intrauterine programming. So initiation of metformin after the 12th week will not be effective in preventing GDM. Categorization of the glycemia during pregnancy. One is normoglycemia, next is hyperglycemia, another is eggy. Summing up, the aim is to maintain maternal 2-hour plasma glucose 99 plus or minus 10 milligrams throughout pregnancy from conception to confinement. So hence the female gender is the key to diabetes prevention. It starts with a healthy pregnancy and prevention of NCD, preventive measure against NCD should start during intrauterine period and continue throughout life from early childhood. So the sequence are 10th week prediction of GDM, 11th week fetal beta cell secretion, and 12th week the treatment started not effective. So to conclude, you can see the first trimester GDM was 15%, that is in and the second trimester it is 22%, and third trimester it was 61% initially. Now the trend is changed. This is in 2007. Now in the first trimester the GDM is 31.5, second trimester 42.2, and third trimester 25.3. So the gestation weeks ideal for screening is 8 weeks. Pre-conception advice and early conception care are vital to obtain the healthy offspring. So prediction of GDM to our PP blood sugar 8 weeks so that the maternal blood glucose remains less than 110 throughout pregnancy, and metformin and MNT to continue until confinement. So hence for diabetes-free generation, focus on the fetus for the future. Thank you.
Thank you, Dr.
If there are
Lakshmi.
any questions, so I am ready to answer. Yes.
Become worse in coming years, and vascular disorder is one of the major complications associated with this diabetes mellitus. It is about 2 to 4% higher in type 1, either in type 1 or type 2 diabetes mellitus. And atherosclerosis is the underlying cause for these vascular disorders, which is of multifactorial in nature. And coming to the factors associated with it, we have hyperglycemia, increased lipid concentration, and oxidative stress due to hyperlipidemia and the aging process. And hyperinsulinemia, which is one of the predisposing factor of diabetes mellitus, is among the factors associated with the atherosclerosis, and alteration in the coagulation profile is another factor. So with this background, I would like to introduce my study implications, that is the rationale behind my study. That is, among the factors which I have explained now, dyslipidemia and oxidized LDL are the important pathogenic mechanisms of endothelial dysfunction. So it has been shown that treatment of dyslipidemia with the hypolipidemic drugs improves the endothelial dysfunction in non-diabetic dyslipidemic individuals. So this trial can be extrapolated to the diabetic population as well, which can give a wonderful results. So with this rationale, we have started the study. So the initial lesion of atherosclerosis starts with a change in the endothelial cell function. So assessment of the endothelial function can be used as an early marker of future atherosclerotic disease. So because of invasive nature of the study tests which are being used, that is angiography, which is being used for assessing the endothelial function, precluded its use in the routine clinical practice. So later on, the development of study of flow-mediated vasodilatation by color measure, it has provided an extremely useful tool for assessing the endothelial dysfunction. The primary aim of our study is to demonstrate and determine whether there is any impairment in the endothelial dysfunction occurring in the patient with the type 2 diabetes mellitus, and after that to determine whether this dysfunction has been increased in presence of dyslipidemia along with the diabetes. The objective of the study is to assess the degree of endothelial dysfunction by measuring flow-mediated dilatation in peripheral arteries using B-mode ultrasound in diabetics as well as non-diabetics, which are chosen as control in our study. To compare the flow-mediated dilation between the two groups, and also within that, because we have studied the study group into two types, that is groups with dyslipidemia, diabetic with dyslipidemia, and diabetes without dyslipidemia, and we want to compare the FMD between the two groups and correlate the lipid profile values with the degree of endothelial dysfunction, that is the flow-mediated dilatation in these two groups. And the study material includes 90 patients who are included in the study, or diabetics mellitus diagnosed by immediate criteria. The ideal criteria we have included is fasting blood glucose level more than 125 milligram per deciliter, and postprandial glucose being more than 200 milligram per deciliter. And dyslipidemia being categorized as per the NCEP ATP3 guidelines, with total cholesterol being more than 150 and LDL being more than 130 milligram per deciliter, and HDL cholesterol being less than 40 in case of males and less than 50 in case of females. We have excluded all the subjects who are clinically evident of micro or macrovascular complications of diabetes. We have excluded this based on the history. We have collected clinical history from the patient, that is, who are having previous attacks of stroke or transient ischemic attack, and also any clinical evidence of peripheral vascular disease or peripheral neuropathy that we have confirmed by clinical examination, and investigative evidence like ECG evidence of coronary artery disease has been excluded, and diabetic retinopathy being excluded using the fundus examination. And we have taken the help of laboratory for excluding the diabetic nephropathy using for checking for the presence of overt proteinuria or serum creatinine more than 2 milligram per deciliter. And coming to our study proper, we have included the clinical examination as measuring of blood pressure, the resting state, and collected the data of weight and height to calculate the body mass index. And we have performed the extensive cardiovascular examination to exclude any cardiovascular disease. And biochemical assessment was done for fasting blood glucose and postprandial blood sugar, and comprehensive lipid profile, including total cholesterol, total triglycerides, and HDL levels. And we have calculated the LDL using a pre-evolved formula, and we have also calculated the HDL cholesterol ratio. for assessing the risk of the cardiovascular disease. So all these parameters were analyzed using the Siemens Dimension Expand Plus in the biochemistry laboratory. And the brachial artery diameter was measured on B-mode ultrasound images to assess the flow-mediated dilation. Later, the flow-mediated dilation was calculated and it was presented as a percentage change from baseline to the hyperemia. That is, the formula for calculation of FMD is diameter at the base level minus diameter after hyperemia by diameter at the base level into 100. And severe endothelial dysfunction was considered when the flow-mediated dilatation is less than 4.5. So regarding the scanning, we have performed a resting scan to measure the velocity of arterial flow using a pulse Doppler. And the increased flow rate was measured by inducing, the flow was increased by inducing the inflation of sphygmomanometer curve, which is placed at around 5 to 10 centimeters distal to the scanning part of the artery. And it was inflated to a pressure of 200 millimeters mercury, which is retained for 4 to 5 minutes. Later, it was released or deflated. A second scan was performed continuously for around 30 seconds before deflation and 90 seconds after deflation of the curve. And a repeated recording of flow velocity was done 50 seconds later after the curve was released. Now the FMD was calculated using these results and the average results of the two observations were recorded. And these are the results that we have got. This is the age and gender distribution of the cases. Most of the cases were found among males and in the age group of 51 to 60 years, and age and sex matched with the control group. And these are the baseline clinical characteristics in the study population. So if you can see, there is no significant age or BMI between the cases and controls. And there is a significant change or less significant change, you can say, in the cholesterol levels between the controls and cases, because the cases we have chosen are diabetics and the controls are normal subjects. And there is a strong significant change. You can see the LDL cholesterol levels has been strongly significantly increased in cases when compared to the controls, indicating that they are more prone for cardiovascular disease. And we have total cholesterol HDL, which is the recent marker for cardiovascular disease, shown a significant difference between the controls and cases, with significant increase in the cases when compared to the controls. And this is a table showing the comparison of lipid profile between diabetics with and without dyslipidemia. Within the cases, we have categorized into two subgroups, those with diabetes with dyslipidemia and diabetics without dyslipidemia. If you compare all the characters, we have found that there was no much significant difference between the age group, that is age matched, we can say, and most of the diabetics are in the same age group. And BMI, we can see a lot of difference. We can see the thing is, we have found diabetics with dyslipidemia is of BMI is more in group with the diabetes with dyslipidemia, and total cholesterol, LDL and triglyceride and total cholesterol HDL ratio are extremely significantly increased in case of diabetes with dyslipidemia group, whereas HDL has decreased significantly in case of diabetes with dyslipidemia group. And these are the ultrasound images. So this is the image showing normal dilatation of the brachial artery at the baseline to 90 seconds after the cuff release. This is the normal dilatation when there is no defect in the endothelial dysfunction. And this is the presence of normal reactive hyperemia that can be seen when there is a normal increase in the peak systolic velocity. And this is the increased diameter of brachial artery from baseline to 90 seconds after cuff release. If you can see here, there is a increased diameter from baseline. So before application of the pressure, and after application of the pressure and depletion of the cuff. And this can be reflected in the reactive hyperemia as shown in the as shown here. There is reactive hyperemia you can see by indicated by increase in the peak systolic flow velocity. If you see here, this is the endothelial dysfunction you can observe because there is a complete absence of dilatation of the brachial artery from the baseline to 90 seconds after cuff release. So if you can see here, there is a similar absence of reactive hyperemia you can see as shown by normal peak systolic velocity. And this is a table showing the flow mediated dilatation between the cases and controls. If you see, there is a significant decrease in the FMD value when compared to controls in the cases group. And within the diabetes group, there is not that extreme significance you can see. Still, there is a difference in the FMD value between the diabetes with dyslipidemia and without dyslipidemia. There is significant decrease in the FMD. Not much of significance, not extreme significant, but significant difference you can find between diabetes with dyslipidemia group and diabetes without dyslipidemia group. If you see the number of cases with endothelial dysfunction, in the controls we can see with the FMD dilatation less than 4.5, it is almost 0, and it is in the dyslipidemia group, it is around 41%. FMD with more than 4.5, it is comparatively less in dyslipidemia group when compared with the, that is 59% when compared with the dyslipidemia group in cases. Okay, if you see here in cases, FMD less than 4.5, it is around 26%. If it is FMD more than 4.5 is around 74%. And correlation of FMD with the diabetic dyslipidemia on univariate analysis. We have correlated the FMD with all the parameters we have taken. We found that all the parameters being significantly negatively correlated with all the parameters with the FMD, except for HDL. So analysis of the tables that I have presented, if you take overall, the present study shows that there is an impairment of flow mediated dilatation in diabetics when compared with the normal subjects. Within the diabetic group, we found that patients with dyslipidemia have shown significant impairment in FMD when compared with the patients without dyslipidemia. And also we found that a significant negative correlation was found between total cholesterol, LDL-C, triglyceride, and total cholesterol HDL ratio and the degree of impairment of endothelial dysfunction, which is being measured using FMD. I have presented here some of the studies which we have used as a literature for comparing our study. So a study by K. Bhargava et al., they have showed that a significant endothelial dysfunction in diabetes been shown when compared with the normal subjects. They have considered not just the comparison between diabetes and normal subjects, but also they have seen that similar degree of endothelial dysfunction being seen in patients with coronary artery disease even without diabetes mellitus, because endothelial dysfunction is common basis for atherosclerosis either in people with diabetes or non-diabetes with different kind of rationale. And another study by Uday Jadhav et al. Has shown that there is a significant impairment of endothelial function occurred in diabetics when compared with the non-diabetes, which is exactly similar to our study. And they also found that endothelial dysfunction was more profound in the dyslipidemia group, which is absolutely coinciding with our study. And Clarkson et al. In the study, they have shown that endothelial function was significantly impaired in diabetics as compared to controls, and they have not done this subgrouping of the diabetes with dyslipidemia and without dyslipidemia. Yuhai et al. Have demonstrated that FMD of brachial artery was significantly impaired in diabetes, but the impairment was more marked in the presence of peripheral arterial disease, dyslipidemia, and diabetic complication. They have added one more disease they have considered as peripheral artery disease along with the dyslipidemia, which is being excluded in our study. Erongyu et al. Have shown that compared with the type 2 diabetes patient with normoalbuminuria, patients with microalbuminuria had more prominent endothelial dysfunction. That means they have included the subjects with the complication that is that is a diabetic nephropathy at the early stages, which we have excluded from our study. Antonoids et al. Have shown that endothelial dysfunction function was better in healthy controls when compared with the patient with diabetes and coronary artery disease or patients with diabetes alone. It is a clinical trial where they have used vitamin C as a supplement to find out the use of antioxidant role or the role of antioxidant in controlling this vasodilatory response. Summarizing our results, it was found that FMD, which is a non-invasive method of endothelial functioning assessment, plays an extremely useful tool, and is a close correlation of endothelial function has been found in the human coronary as well as peripheral vasculature. So it can be reproduced the similar results in the brachial artery among the peripheral artery we have chosen in healthy subjects as well as in patients with atherosclerosis. So it can be concluded that B-mode ultrasound scan, including brachial artery FMD, may be of clinical value in the screening for endothelial dysfunction. And suggestions for the future from the study, we can extrapolate that assessment of arterial FMD responses might provide a valuable tool for risk stratification of patients with type 2 diabetes, especially for those with dyslipidemia. Along with the FMD, we can use another non-invasive technique, that is DNA array technologies, which helps to identify target genes important for different phases of atherosclerosis, which is costlier as well as it is less available tool. It may replace mere angiographic detection. Till now, angiography has been extensively used to detect the vascular disease. Rather than at the early stage, we will generally go for the assessment of angiographic studies, especially when there is a complication being detected in routine clinical examination or in ECG findings or echographic findings. So we can replace this with a FMD, which can be helpful to detect the risk stratification at an early stage, and it can be useful for not just diagnosis as well as treatment. We can take the help of genomic approach as well wherever it is feasible. Advantages of this study is assessment of endothelial function using FMD technique being a simple, economical, and non-invasive as well as widely available test. It can be used for both diagnostic as well as therapeutic purposes for early diagnosis as well as treatment. And limitations of the study, we found that HDL did not show any clinical significance, or it is independent. It is statistically independent. So it may be because we have taken a small sample size. If you consider a big sample, we can find a significant stage. And what we have studied is a cross-sectional study. If you have done a cohort study with a long-term follow-up of the subjects, we might have confirmed our statement for prediction of the future atherosclerotic cases based on the endothelial dysfunction. And we also found that some of the cases were on drugs that are proven to improve endothelial function. This could be a confounding factor in the present study. So we might have excluded the persons who are on treatment. So these are the reference, and thank you for giving this opportunity, and the session is open for questions. Thank you.
Thank you, Dr. Usha. That was an excellent presentation. Hope the participants have learned and benefited by sharing your research.
That I came across, and specifically I have given this title, Triangle of Symmetrical Peripheral Gangrene, that is caused by whether diabetes, whether it is DIC or vasopressor. It's the question. So the agenda what I will be going throughout this is like introduction and the following thing. So here, first of all, we need to understand how this term called symmetric peripheral gangrene has come into the world, into existence. So it was first of all found who Fishberg in 1938, he found in a patient who had cardiac failure. He found this patient presenting suddenly with symmetric peripheral gangrene. So it was suspected probably it is related to some angioplastic in origin. So in later few years, Perry and Davy also found the same type of presentation in patient having cardiac failure, whether this patient did not have any large artery occlusion, very notable here. So in few years later, again, it was found in patient who had fatal ventricular tachycardia by Abraham in myocardial patient. So in few years later and in recent present, we can find this kind of presentation, patients who are presenting with sepsis. Now, before going ahead with this, I just want you all to know what is this symmetrical peripheral gangrene? What does it mean? What is the definition? So this is the definition that I want to give you here all. So it is mainly characterized by sudden peripheral, frequently symmetrically involving the extremities in the absence of major any occlusive disease. So here this is, I want to here present a case who was with a similar presentation, who did not have any major occlusive disease. So I here present to you a case, 67-year-old male patient. He presented to me just with loose stools and vomiting, 5 to 8 episodes only. And he also had left upper limb swelling, plus fever and pain for 24 hours. So he also complained that decreased urine output for more than 24 hours, approximately 24 hours. And he also gave a history of like plaque psoriasis was present for nearly 1.5 years. He was on prednisolone for 5 mg. So then diagnosed also diabetic for a year and was taking only metformin 500 mg OD dose. So whether this diabetic is steroid induced? Yes, maybe or may not be. And this is the first presentation on the day of admission, patient of the left upper limb, how his plus and the like sepsis is presenting. So if you see on admission, what I saw, the blood parameters and vitals, I want to comment on it. BP was 70/40, pulse rate was 130, saturation was 75% in room air, and respiratory was 36 per minute. And GCS was more or less okay, but still patient was having low GCS 10/15. So ECG did not show anything new much, but it was just a sinus tachycardia. Chest X-ray just showed up increased bronchoscopy marking, but there was a mild pleural effusion on bilateral chest. So ABG, I have done it. It was showing a metabolic acidosis, blood culture and swab culture from the upper limb of the left side I have taken and sent. On day 1 admission, if we see the blood parameters, we can see here hemoglobin and platelet is more or less normal, but the total count was elevated. That was 24,000. Here, if you see RBS, it was absolutely more or less in control, well controlled. And CRP, RBS along with that, if you see HbA1c, absolutely to showing that sugar is in control, 7.2. CRP is 72 and creatinine, if you see, it is 3.2. Patient also complained of decreased urine output. If you see AST, ALT, that is liver enzymes, were quite 5 times the higher. So suspected with all this parameters of vitals and this parameters, I suspected sepsis. So here ABG report, what it is showing. So the diagnosis I came to a conclusion, most probably it is septic shock with the patient is in DIC, probably secondary to this left upper limb necrotizing fasciitis possibility. So started with considering the vitals not very stable, BP was very low, started on vasopressor, noradrenaline and dopamine. Oxygen supply and NIV was continued for 3 days. Antibiotic empirically started with meropenem and fluconazole, suspecting probably some fungal infection as well. Then I also took a surgery opinion. He advised like let the patient's vitals be stable, then we'll plan for debridement. and the DVT stockings of the bilateral lower limb was placed, heparin BD was going on. So here is the day 4, the blood parameters. More or less, you can see the total counts are not very much relieved in spite of 3 days of antibiotic, higher antibiotic. Total count is still 25,000. Platelet, if you see, it has been dropped from 1.5 lakh about to 81K. And creatinine, if you see, there is a mild decrease. ABG has almost normalized, but however, CRP is persisting to be high. So on day 4, procalcitonin was repeated. It was more than 200, and blood culture and urine culture had come by then. It was showing no growth. But the wound swab showed E. coli presence. 2D echo, we got it done, just planning to shift patient for surgery debridement. So if we see EF is low, global hypokinesia was also present. So on day 4, I was doubting, should we really send the patient for surgery, but I felt it is very much needed. So persisting unstable vitals intermittently planned for the worsening of the left upper limb. Left upper limb discoloration. I planned for the debridement. So the first debridement was done. This is the picture of the first debridement. Post-operatively, I was called by a surgeon to OD saying that patient's saturation is very low. Ma'am, come immediately. I went to assess the patient there, and I found that patient was quite stable and he was out of the anesthesia and he was able to talk to me, and he was responding quite conscious oriented, but the saturation was low. So I touched his arms and peripherally the lower limbs and checked. It was cold, clammy. So suspected probably the AC and the cold weather that is making him. But however, I told the surgeons, please shift back the patient to ICU. We'll see the whatever it is. I will take care of the patient. So they shifted the patient back, and the night after 3 hours, I again reviewed the patient, and patient complained to me, I'm having all bilateral 4 limbs. I'm having a severe pain and burning sensation. And when I really noticed, there was mild discoloration of all the 4 limbs. I found it. And according to wound culture, it was meropenem sensitive. So we continued, however, added on cholesterol also considering the count and the limbs being worsened. If you see, this is the lower limb, that is the feet, the discoloration you can note here very well. How it was on normal on the admission. DVT stocking is placed, still it is showing some amount of like thrombosis. So on day later, we planned for Doppler on day 6, and it was all normal. Arterial Doppler, venous Doppler, color Doppler, all 4 limbs were done. It was all normal. I was suspecting also whether it is any autoimmune disease. So just wanted to rule out ANA. So we got ANA and ANA profile, which was absolutely normal. So I was wondering, what is the etiology? Why is this patient going for all this? Then suspected probably secondary to infection itself, the sepsis, the counts are high. So I was suspecting that. On very next day morning, I was also called by a duty doctor. Ma'am, patient is continues to have hypoglycemia. So constantly they pricked on the finger to see the sugar, and it was constantly showing 40 mg in spite of every hourly 25 dextrose was given. So I asked the duty doctor to send the sugar value to the lab. And so I told I came back and saw the patient still all 4 limbs of cold, clammy extremities. And in spite of we had given in between we had given him good warmer and warmth was given, still it was not much better. So, but patient vitals were more or less stabilized, and we had stopped NORAD and dopamine by day 4. So this is really the questionable whether it is DIC that has caused. The DIC symptoms, if you see here, patient had infection, thrombocytopenia, and patient also had intermittently hematuria, and showing the features of microthrombi and macrothrombi suspicions was kept here for DIC. So the other thing is, as I was reading through many articles to know how to treat this patient, I also found the vasopressor can also cause symmetrical peripheral gangrene. So my patient, absolutely, he had vasopressor, dopamine and noradrenaline was continued for him. So this was the picture of his right upper limb, which was extremely showing the peripheral gangrene. So here, if you see, we need to understand going further to know how is this pathophysiology affecting how it is presenting the symmetrical peripheral gangrene. So first of all, I want to tell you what is the triggers if you see for acute DIC, cardiogenic shock and septic shock. So my patient had here septic shock as well, plus cardiogenic shock. He was in EF was less than 45 and he's had full global hypokinesia. And other triggering factors, risk factors, if you see hypertension, vasopressor, and shock liver. Absolutely, my patient liver enzymes were 10 times higher, 5 times higher than the normal value. So these are the causes for symmetrical peripheral gangrene. So we need to understand while patient is developing, these are our normal pathway, which is for coagulation, the anticoagulation getting inactivated or impaired, producing this small microthrombi. So we need to be careful on giving vasopressor, giving when the patient is in septic shock, in saving the life, as well as we need to be aware of what is happening. So this is my patient on day 9 present. We see his upper limb, this on the right, and this is his left upper limb. Again, he had mild discoloration of the left upper limb with necrotizing fasciitis. So we again second time took him for debridement. This is the second debridement that was done. And if we see his blood parameters on day 10, we can see his counts almost normalized. Okay, then platelet still lower, 30K, and sugar was more or less, it was okay. Creatinine also has come down to 1.4, and CRP you can see series of coming down, and ABG almost normalized. So on day 14, we had sending him on vacuum dressing to home. So prior to sending him home, we had done some of the blood tests. It was all good. So we had sending him home on day 16 with this. On day 26, patient came back for the follow-up. And you can see vacuum dressing is being removed here. And if you see following removal, we found that his hemoglobin was very much reduced, 4.6, and other counts and other creatinine values were normal. So he was given 2 units of blood transfusion here. And he underwent on day 28 for the skin graft and the amputation of the right upper limb. So this is the left upper limb. The necrotizing fasciitis is very well healed following the vacuum dressing. So we need to understand once again how is this symmetrical peripheral gangrene progress. Specifically, those physicians and who are caring for the patients in the critical care need to realize. So you can see here platelet count gradually coming down on days like 3 or 4. My patient absolutely he had 1,75,000 on admission, and gradually you found him coming to 30,000 on day 8 or 9. So this can happen in symmetrical peripheral gangrene. And we can also see here how this even heparin-induced thrombocytopenia also can happen because of creat was high. I had given him heparin. So possibility of heparin-induced as well as the sepsis-induced thrombocytopenia also can be there. And you can see here hypertension, vasopressor, cardiogenic shock, all this gradually leading to this kind of symmetrical peripheral gangrene. So if we see on day 33, we found his blood transfusion, following blood transfusion, he got his hemoglobin normalized and CRP almost normalized. And we can see here why I presented this case is we all need to be aware how DIC, vasopressor, infection, diabetes, all this can evolve gradually the patient into symmetrical peripheral gangrene. So on timeline, this all, if you see, this all 4 things itself can lead the patient for higher mortality as well. So timeline intervention matters a lot in all our practices. So we need to focus when this kind of patient presents to us, whether sepsis, whether diabetes, whether DIC, whatever it is, we need to be on foot on this one to get ready for treating the patient with good control of diabetes and concentration on sepsis for higher antibiotic. And we need to save the life. We need to focus. Mild gangrene does not matter. Okay, so here this is the another case another patient, a female patient. She is also around 65-year-old. She also presented with a similar complaint, but this patient had pyelonephritis and she also had creatinine high, low urine output, all that. So here I don't want to present this case longer, but I just want to show you this is another patient who had presented to me in this hospital with the similar complaints, and you can see this how her bilateral gangrene is present. So how we understand this can happen is my patient on the first one whom I presented, norepinephrine dopamine was given for more than 72 hours. Specifically, if we give a higher dose of all this norepinephrine or dopamine can cause this kind of symmetrical peripheral gangrene. And another thing is DIC itself also can cause the symmetrical peripheral gangrene. Another thing is we all know diabetes with uncontrolled patients can go for macrothrombi. But however, we rule out here. So this is the picture of the upper limb. And here I just want to show you also the similar studies that has been done in some other hospital, which was presented recently 2022. You can see here 4 patients whom they have presented is 2 patients are below 40 and 2 patients are around 60 years old. And you can see here day of ischemia or vasopressor following how many days that they have developed these symptoms are in day 3, day 2, which is very much similar to my patient as well. So here you can see one patient died, other 3 patient has been survived with the mild gangrene. So this is how happened to my patients also. So very much it matters on time presentation. So here learning points is management of sepsis and vasopressor use lead to symmetrical peripheral gangrene. We need to keep at the back of mind, but we need to get a proper history of the patient. Sometimes patient may not tell us diabetes or any other issues. So we need to get a proper history from the relatives and the patient. And we need to be early recognized and prompt treatment for whether diabetes, whether it is sepsis or whatever conditions, we need to be alert enough to present. And another the important thing is we need to keep constantly conversing and counseling the relatives to understand what is really happening to patients and what are we treating with. So the more we give clear explanation, the more relatives are very much attuned with us and they will go ahead with us and they won't get aggressive with us. So I found that these relatives were quite at ease with me when I was explaining to them, like in a day 2-3 times, sometimes I had to explain to them regarding what was happening to him. So they were quite at ease with me for the presentation and for the treatment, and as well as they went well. Within 1 month, it almost settled very well. So the summary is I want to really once again tell you the same thing. Early recognition, prompt management of sepsis, it optimizes the process of weaning the ionotropes, as well as we may need to, we can avoid also symmetrical peripheral gangrene if we little more early we do it. So this we keep in mind, and these are the few references that I have taken for this presentations. So thank you for giving me this great opportunity to present this, my rare case that I found in my hospital. Thank you for all of your patient listening. So any further questions, I am ready for it.
Thank you, Dr. Josvi. That was an excellent presentation regarding your case of gangrene, and hope the participants
on diabetes and endocrinology, and the respected scientists and researchers present here. Today, I am going to represent my talk on the biopolymer grafted nanocomposite for the management of diabetic mellitus. Aim of my talk is the synthesis a biocompatible and cost-effective and biodegradable nano-wound dressing. An objective my talk is to discuss the risks of diabetes mellitus and diabetic foot ulcer, and also to discuss the conventional treatment of diabetic foot ulcer, and then the application of nanotechnology in DFU treatment and evaluation of wound healing ability of the silver nanofiber in DFU treatment. Next. In an introduction of my, now I am going to the introduction part, the slide number 4. The diabetes mellitus is a chronic health problem. In the 21st century, DMM is an endocrine disorder and increasing rate of DMM is more in developing countries than that of developed countries. And DM has emerged as one of the serious health threats with a huge socioeconomic burden. Here I am trying to give the schematic distribution of increase of the percent of DMA by the prevalence of million by IDF region in the adults greater than 65 years in 2019 and in the future in 2030 and 2045. Now I am going to discuss what is diabetic foot ulcer. So it is the wound that creates due to the diabetes DM. DM increases risks of infection and DM decreases wound healing due to impairment of metabolic activity. DFU is a chronic wound that affects the lifestyle patient and consequently heightening the risk of mortality. Worldwide, 9.1 to 26.1 million people with DM develop DFU annually, and it is the schematic diagram of pathophysiology of DFU. The slide number 6. Now here we use the nanofibers as structures are very similar to the natural extracellular matrix. Therefore, we use the nanofiber for the treatment of DFU. And here we use electrospinning treatment to synthesize the nanofiber. Electrospinning is a convenient, inexpensive, and common technique that is widely used to produce nanofiber. Biodegradable polymers were fabricated to heal diabetic ulcer. Cellulose nanocrystals have been widely used as a reinforcing material to improve nanofiber mechanical and thermal properties. Chitosan has the ability to promote skin regeneration and skin wound repair. And polycaprolactam has impressive biological properties and mechanical strength for employing in wound healing therapy. And here we use silver as a metal nanoparticle in the synthesis of nanofiber. We use silver because silver is widely used in antibacterial composite due to its broad spectrum, bactericidal effects, and durability. Here in slide 7, we try to discuss the difference between the normal wound and diabetic wound healing. In slide 8, we give the schematic diagram of application of nanotechnology in DFU treatment. Different types of nanoform like polymeric nanoparticle, gold nanoparticle, carbon nanotube, quantum dot, silver nanoparticle, solid lipid nanoparticle, nanofiber, dendrimer, and liposome are used in the nanotechnology-based delivery in chronic wound healing. Wound healing mechanism of biomediated nanoparticles are given by the schematic representation in slide number 9. Here the different type of mechanism takes place like angiogenesis, epithelialization, collagen fiber synthesis, and immunomodulation. Silver nanoparticle or other nanoparticle inhibit the growth of microbes in wound. This is the antimicrobial mechanism of silver nanoparticle. First, silver nanoparticle enters to the cytoplasm of cell by disturbing the cell permeability. Then it creates reactive oxygen species, and by creating reactive oxygen species, it increases the oxidative stress in the cytoplasm of the cell. Then by this, it damages the DNA replication, protein denature, Then it also disassembles the ribosome, dysfunctioning the mitochondria, and disruption of electron transport chain and protein motivate force. And thus it damages the whole cell. And thus it control the growth of microbes. By this way, it treats the healing of the wound. In silver nanoparticle, we screening for pathogens that are Staphylococcus aureus, Pseudomonas aeruginosa, Candida albicans, and one fungal. Here we see that in Staphylococcus aureus, when the increase of the concentration of silver nanoparticle, the growth of bacterial decreases. In case of 4 pathogen, same reaction is happen. So we concluded that biopolymer supported silver nanofiber is a successful candidate in the treatment of diabetic foot ulcer. Then in slide number 12. Inside slide number 12, we in table form we stated the MIC of the silver nanoparticle which inhibit the growth of the microbes. Here we notice that a lower concentration, it can inhibit the growth of Staphylococcus aureus is 35 microgram per ml. In Escherichia coli, it is 15 picogram per ml. For in case of Bacillus subtilis, is 30 microgram per ml, and Klebsiella pneumonia is 15 microgram per ml. And for to discuss the mechanism of to inhibit the growth of bacteria or fungal, we determine the percentage of reactive oxygen generation and when leakage also increases. We also determine the antioxidant activity of the silver nanoparticle, and here we determine that in GPPS assay we determine the IC50 value, and which is nearly 35 microgram per ml. We also determine in BSA, bromine serum albumin assay, we also determine the anti-inflammatory activity of the silver nanoparticle. In vitro study, we also determine drug delivery ability of silver nanoparticle, and in drug delivery activity, silver nanoparticle show efficient activity. So we can conclude that silver nanoparticle successfully inhibit the growth of microorganism or microbes in diabetic foot ulcer, and we can use in case of in the delivery of drug to treatment of the DFU. Here there is some recent work, remarkable work done in the field of the treatment of DFU. These are the says S. et al. The potential of silk sericin-based nanofiber mesh for wound dressing application. Y-agarwal group did the curcumin-loaded polycaprolactin polyvinyl alcohol silk fibrin-based electrospan nanofiber and in vitro and in vivo studies, and M. Chaudhuri group performs carefree healing of full thickness diabetic wounds, a unique combination of silver nanoparticle as antimicrobial agent, calcium alignin nanoparticle as hemostatic agent, fresh blood as nutrient growth factor supply, and chitosan as base matrix. And other work also we here reference that are the Singh Work the cytocompatible antimicrobial dressing, cesium, cumini cellulose, nanocrystal decorated with silver nanoparticles, accelerate equine and diabetic wound healing, and Liao work a bioactive multifunctional heparin grafted aligned polylactidoglycolide curcumin nanofiber membrane to accelerate diabetic wound healing. These are the schematic diagram of their work, and FCs are preparation and characterization of chemically tempo-oxidized and mechanically disintegrated secretin nanofiber for enhanced diabetic wound healing. Here an excellent nanofibers matrix based on gum-tecaran poly, the eta-caprolactam polyvinyl alcohol for application in diabetic wound healing. Here the advantage of electrospinning nanofiber in DFU treatment. Here this method is a very cost-effective and biocompatible and biodegradable method, because in this case, where the in electrocellulose cytosine they are biopolymer, and in for reducing of silver nitrate to silver zero state, we use plain extract. Plain extract is a reducing agent. So therefore, we apply a green method to synthesize a cost-effective and environment-friendly nanofiber in DFU treatment. And also nanofiber have an antibacterial, biodegradable, on-skin regeneration advantage, so it can efficiently inhibit the growth and in the treatment of DFU. And conclusion and future purposes of my work is that is silver nanofiber is expected to be an alternative wound healing paste to overcome the obstacle for traditional wound healing bandage. Biometric electrospin nanofibers wound dressing loaded with materials that possess properties of dual antibacterial and tissue repair would be developed to address this problem. Silver nanofiber is a promising nanofiber membrane to improve the clinical efficacy of diabetic wound healing, which is expected to provide a basis for future development of material-based therapeutics. Nanotechnology-based remedies will possibly be the next frontier poised for breakthrough in meeting the clinical needs of chronic wound healing. Wound dressing paste will be synthesized in large scale for an industrial purpose that will help in the development of new technology. And diabetic patients, especially in developing countries, will get benefit from this cost-effective paste. We heartily acknowledge the director of CSR and my supervisor and organizing committee of 4 global webinar on diabetes and endocrinology and DS Department of Science and Technology, Government of India, and all my parents, siblings, and pom-pom. Thank you. This is the summary of my talk.
Family history of cardiovascular disease. So, introduction. Menopause marks the cardio unfriendly state in women's lifetime. Can this be shifted a little? It's not visible over here at the right side. The contents are not visible.
Dr. Gio.
Yeah, it's fine now. Fine. Okay. Menopause marks the cardio-unfriendly state in women's lifetime. Cardiovascular disease is one of the most frequently occurring macrovascular complications associated with many evident risk factors like dyslipidemia, oxidative stress, diabetes, hypertension, obesity, endothelial dysfunction, vascular inflammation, and family history of CVD. Family history of CVD modifies future CVD risk depending on the number and age of affected first-degree relatives. Siblings of patients with CVD have about a 40% risk increase, while offspring of parents with premature CVD have a 60 to 75 risk increase. Cardiovascular disease are a group of disorders of the heart and blood vessels, and they include coronary heart disease related to disease of the blood vessels supplying the heart muscles, cerebrovascular disease, disease of the blood vessels supplying the brain, peripheral artery disease, disease of the blood vessels supplying the arms and legs, rheumatic heart disease, damage to the heart muscle and heart walls from rheumatic fever caused by streptococcal bacteria, and congenital heart disease related to malformations of heart structure existing of birth, deep vein thrombosis, and pulmonary embolism, blood clots in the leg veins which can dislodge and move to the heart and lungs. So the prevalence regarding WHO 2011, the non-communicable diseases comprise cardiovascular disease as the maximum 31%, with cancer 13%, respiratory disease 8%, diabetes 2%, and other non-communicable diseases at 10%, injuries 9%, whereas communicable maternal perinatal disease comprise 27%. So according to the WHO, 17.5 million deaths in 2012 were attributable to cardiovascular disease, with 7.6 million being due to the result of ischemic heart disease. Now, prevalence in India. Again, non-communicable diseases, among these cardiovascular diseases comprising maximum, that is 24%, cancer 6%, respiratory disease 11%, diabetes 2%, other 10%, whereas communicable disease comprise 37%. Now, risk factors leading to cardiovascular disease can be host factors, that is genetics or past history, family history, then environmental factors, noise, air pollution, and other risk factors, lifestyle factors, diet, smoking, physical activity, all these lead to cardiovascular disease. Now, adiponectin, it's a 244 amino acid long polypeptide found in human encoded by adipoq gene. It is mainly synthesized and released from adipocytes of adipose tissue. It is also synthesized from cardiomyocytes, skeletal muscle, and osteoblast. Synthesis is complex and involves number of post-transcription mechanisms. An anti-inflammatory adipokine, which protects against metabolic and cardiovascular disease. It modulates several metabolic processes, that is glucose regulation, fatty acid catabolism. It enhances insulin sensitivity in liver, stimulates muscles to oxidize fat, and has vascular protective effects. Clinical studies show low adiponectin concentration as cardiovascular risk factor, whereas polymorphism in the promoter region of an adiponectin gene is significantly associated with low adiponectin levels and type 2 diabetes mellitus. So adipoq gene is located on chromosome 3 with Q arm at 27 position and contains 3 exons and 2 introns spanning a 17 kb region. So these are the various effects of adiponectin on various parts of the body. On liver, it affects it decreases glucose output, fat accumulation, as well as inflammation. On muscles, it increases glucose uptake, decreases fat accumulation, increases energy expenditure. And for heart, it decreases inflammation, endothelial adhesion, foam cell formation. And all these factors are protecting from insulin resistance, type 2 diabetes mellitus, and coronary artery disease. So again, genetic factors, adiponectin gene polymorphism, lifestyle changes, high fat diet, sedentary lifestyle, all these lead to low levels of adiponectin in blood, which leads to insulin resistance, leads to type 2 diabetes mellitus, along with hyperlipidemia and hypertension comprising metabolic syndrome, all these which leading to atherosclerosis. So rationale of the study was that role of genetic factors in CVD pathogenesis is very much clear. Of course, adipoq association is also there, and other risk factors are also included in the study, were included in the study. So our hypotheses were that whether family history of CVD acts as a risk factor or not. So our aims and objective were: the present study was aimed to screen the prevalence of 276G to T polymorphism of adipoq gene in menopausal women of Punjab with and without the family history of CVD, and does positive family history of CVD play an individual role as risk factor for CVD in menopausal women of Punjab. So participants, case control study design and selection of patients were done. Study was passed by institutional ethical committee. Informed consent was taken by all the participants. The study group included 265 diagnosed CVD menopausal women as cases with and without family history of CVD, and 258 menopausal women without CVD as controls with and without family history of CVD. All the females were screened for adipo-Q polymorphism, and the statistical analysis was performed by SPS software. Genotyping. DNA from the blood was isolated by salt precipitation method. Then concentration was detected by UV photometer, and the quality of DNA by gel electrophoresis. Genotyping was done by RFLP PCR, and then the detection was done at 2% agarose gel. So this is the picture of adipocene gel polymorphism, in which we have heterozygous type GT, homozygous wild type GG, and TT as risk genotype type. So sequence of specific primers for adipo were forward primer as well as reverse primer. Conditions for PCR were initial denaturation at 95 degrees centigrade for 5 minutes, denaturation at 94 degrees centigrade for 45 seconds, annealing 58 degrees centigrade for 45 seconds, primer extension at 72 degrees centigrade for 45 minutes. These all steps were occurred 35 times, and then the final extension 72 degrees centigrade for 5 minutes. Now we come to the results. So prevalence of 276 adipoco gene in total menopausal women with and without CVD. So in this case, we found that the total frequency of TT wild genotype was more in cases as compared to the controls, as well as T risk allele was also more as compared to the controls. So this is just the graph showing that TT genotype frequency is more in cases as compared to the controls. Similarly, T alleles frequency is also more in cases as compared to the controls. So all the genotype frequencies of the studied SNP were subjected to Hardy-Fibing equilibrium. It was observed that the genotypes in both cases and controls were not in the equilibrium. Frequency of the heterozygous genotype is more in controls as compared to the homozygous risk type and homozygous wild type menopausal women. So the reason for this may be that the SNP 276 G to T is in linkage disequilibrium with some other polymorphism. So significant difference in the genotype and allele frequency of adipo-Q G to T polymorphism was observed between menopausal women with and without CVD. Now this is the genetic model analysis. In this analysis, it is very much clear that the recessive model is showing ninefold more risk of CVD as compared to the dominant model, whereas the heterozygous model is protected towards CVD. So the model analysis revealed that under recessive model, the TT genotype increases the risk of CVD by 5 folds even after correcting for confounding factors such as menopausal age, BMI, waist circumference, and WHR, whereas heterozygous model provides protection when compared with menopausal women without CVD even after correcting for confounding factors. So prevalence of 276 GT of adipoco gene in menopausal women with positive family history of CVD. In this case, again, there is a significant difference of the frequency between cases and controls regarding TT genotype, whereas there is no significant difference of T allele among the cases and controls. So this is just a graph showing the frequency, more frequency of cases as compared to the controls. There is a little high frequency of T allele in cases and controls, but the significant is non-significant. So model analysis showing recessive model again for positive family history of CVD. It's 6-fold high risk towards CVD, whereas a codominant model is protected towards CVD. Then the prevalence of SNP in the negative family history of CVD. Again, in this case also, TT genotype frequency is more as compared to the controls with a significant difference, whereas T allele frequency is more as compared to the controls, but the significant is non-significant. So this is the graph showing frequency of TT genotype more as compared to the controls. The T allele risk frequency is also more as compared to the controls, but the significant is non-significant. Now, this is the model analysis for the genotype in negative family history of CVD. Again, the recessive model is showing more risk towards CVD, that is 9-fold as compared to the positive family history, and the codominant model is protected towards CVD. So conclusion is, under recessive model analysis, TT genotype of cases with positive family history of CVD conferred 6-fold high risk for CVD as compared to controls. Interestingly, TT genotype of cases with negative family history of CVD conferred more risk, that is 9-fold for CVD as compared to the control subjects. Moreover, number of women suffering from heart disease with negative family history of CVD was also observed to be more, that is 171 in number, as compared to women with positive family history, in which the number were 94. It means the mechanism underlining the genotype phenotype association is not directly related to 276T allele SNP, whereas another possible reasons could be due to interaction of susceptibility genes, environmental factors, and conventional risk factors, which can be physical activity, dyslipidemia, diabetes mellitus, hypertension, oxidative stress, which contribute significantly to the pathogenesis of CVD. So the study concludes up with the findings that menopausal women without the family background of CVD are likewise inclined to coronary illness in this way. Positive family history of CVD does not appear to be significantly affect CVD in menopausal women of Indian Punjabi origin. Still, the study needs to be warranted in more population. Modifiable risk factors should be planned to reduce the overall risk of heart disease. Regular screening of these factors ought to be kept. To lower the total risk of heart disease, it is important to screen the modifiable risk factors regularly and to increase strong need for public health care system. Thank you.
Midford Hospital, Dhaka. First, I give my gratitude and heartfelt thank you to all the whole organizer committee and scientists conferences to choose me and give me the opportunity as a speaker. Thank you. Okay, now I am starting my article. Association of Hypothyroidism with Type 2 Diabetes Mellitus, a hospital-based experience in a tertiary care center. Diabetes mellitus is a leading cause of death and disability worldwide. Almost 1 in 11 adults in Bangladesh was found to have diabetes, which was recently become a major public health issue. According to the statement of IDF, diabetes prevalence of Bangladesh in the year of 2015 is 7.4%. IDF estimates that 1 in 11 adults has diabetes, 1 in 2 adults with diabetes is undiagnosed, and 12% of global health expenditure is spent on diabetes. Globally, 415 million adults have diabetes, and by 2040, this will raise to 642 million.
Dr. Marana, sorry.
Yes.
Can you
Yes.
please make your slides in a slideshow?
Okay. And does not it show?
The slides are visible, but it is not in the slideshow mode.
Okay, okay. Right? Now it's okay.
It's perfect.
Okay, okay. Thank you. Etiologically, different metabolic defects occurred in diabetes characterized by hypercalcemia resulting from a variable interaction of hereditary and environmental factors and are due to defect in insulin secretion or action or both. The first report showing the association between diabetes and thyroid dysfunction was published in 1979. In high-income countries, approximately 87 to 91% of people with diabetes are estimated to have type 2 diabetes mellitus. And also thyroid disorders are also common. It is second only to diabetes mellitus as the most common condition to affect the endocrine system. Abnormal thyroid hormone levels can also be found in individuals with diabetes. Thyroid hormones are insulin antagonists. Both insulin and thyroid hormones are involved in cellular metabolism, and excess deficit of their one can result in functional disarrangement. Greater the duration of uncontrolled type 2 diabetes mellitus in a patient, higher is the chance of thyroid dysfunction. Studies have shown that hypothyroidism and hyperthyroidism are associated with diabetes. A meta-analysis reported a prevalence of thyroid dysfunction in patients with diabetes is 11%. Another study of Bangladesh revealed that 10% of patients had hypothyroidism and another 9.5% had subclinical conditions. Among hypothyroidism group, around 35% of patients were in between 41 to 50 years of age group, whereas the lowest age group was 51 to 60 years, and 52% of patients of hypothyroidism group had diabetes for more than 5 years. Altered thyroid hormones have been described in patients with diabetes, especially those with poor glycemic control. In diabetic patients, the nocturnal THS peak is blunted or abolished, and the THS response to TRH is impaired. Reduced T3 level have been observed in uncontrolled diabetic patients. The low T3 state would be explained by impairment in peripheral conversion to T4 to T3 that normalizes with improvement in glycemic control. Abnormal thyroid hormone level may be the outcome of various medications that the diabetic patients were receiving. The prevalence of thyroid dysfunction among diabetic patients is varying from 2.2 to 17%, the most common disorder being subclinical hypothyroidism. To conclude, there is a high prevalence of thyroid disorder of patients with type 2 diabetes mellitus, which was further found to be more in female, elderly patients, and patients with uncontrolled diabetes. So, regular screening of the thyroid function in all type 2 diabetic patients would be done, especially on those with uncontrolled diabetes. To evaluate the association of hypothyroidism in type 2 diabetic patient, this is the general objective of my article. It's a cross-sectional observational study. 100 patients with known type 2 diabetes without thyroid disorder attended indoor and outpatient department of medicine and our OPT. Department of Medicine, Endocrinology, Sir Solomula Medical College, Mitford Hospital, Dhaka. Period was 6 months from 19 March to 2018 to 18 September 2018. Patient with known type 2 diabetes mellitus without thyroid disorder attended indoor and outdoor medicine department, endocrine department, and sample was selected by purposive sampling technique. Now, the selection criteria. Patient with known type 2 diabetes mellitus without thyroid disorder, able to perform lab investigation, age more than 30 years, both sexes, patient who will provide the informed written consent to be included in this study. These are the inclusion criteria. Exclusion criteria were type 1 diabetes mellitus, patient with history of thyroid disease, that is thyroid carcinoma, other hypothyroidism, known previously diagnosed hypothyroid patient, goiter, etc. Patient with acute illness, that is sepsis, acute MI, severe heart failure, recent admission in intensive care unit. Patient with hepatic dysfunction, smoking, pregnancy, bronchial asthma on steroid, patient on treatment with drugs interfering with thyroid hormone like amiodarone, lithium. Now, I am showing my result. In this study, this is the demographic characteristics of the patient. The maximum incidence was seen in the fourth decade, that is 44%, and next to it's the fifth decade, that is 32%. Highest incidence of male-female patient was in this age group between 41 to 50 years. Duration of diabetes mellitus, that is, majority of the diabetic patient was suffering for more than 6 years, is 62%. Only 12% patient had a history of diabetes less than 1 year, and 1 to 5 years, that is, number of patient is 26%. Now, here I am showing the T3 level among the study subjects. That is, the T3 level of the study subjects of my study was below 1.86 or below T3 level. Male subject was 12% and female was 15.7%. Within the normal limit, male person was 79% and 78% were female. Serum T4 level among the study subjects below T4 level, that is 9.14, male person was 16% and female subject was 15.7%. Within the normal level, there is 77.4% were male and 76.3% were female. TSH level, low THS level were observed, that is in male person 6.4% and 10.5% in female patient. And within the normal level, male was 74.1% and 73.6%. More than 5, the THS level was observed in male person is 19.3% in case of male and 15.7% in case of female. Association of thyroid abnormality with duration of diabetes. Here we can see easily that the more the duration of diabetes, that is more than 10 years, the number of thyroid disorder percentage is more. That is 14% are observed among the study subject, more than 10 years of diabetic. And within less than 1 year of diabetic, there is incidence of thyroid disorder is more or less near 0. Pattern of thyroid abnormality in the study population. The pattern is observed. The primary hypothyroidism is total 14 cases and subclinical hypothyroidism 4 and primary hyperthyroidism 6, that is 25%, and subclinical hyperthyroidism 2. The mode is observed in that primary hypothyroidism, that is male subject was 50% cases showing primary hypothyroidism and female 60% cases are showing primary hypothyroidism. This is this bar showing the age distribution, that is more middle to elderly age group, that is 41 to 50 years are more to from developed thyroid abnormality with more duration of diabetes mellitus. Status of thyroid function test among the study subjects, that is 26% are thyroid dysfunction and others 74% are showing normal or euthyroid. Here is a graphical graphs between the hemoglobin A1C and thyroid status in the study subject. Among the study subject, that is 59.5% study subjects are showing that is hemoglobin A1C level less than 7% hemoglobin. 54.5% subject with thyroid profile are showing that is euthyroid level, that is hemoglobin A1C is less than 7%, there is less chance of thyroid disorder. And hemoglobin A1C is more than or equal to 8%, they are showing more thyroid abnormalities, that is 69.23%. This chart showing that is all of the thyroid disorder among there is hypothyroidism, that is 18% primary hypothyroidism are associated with type 2 diabetes mellitus. Now I am going through some discussion. Total 100 patients of type 2 diabetes mellitus in the Department of Medicine and Endocrinology are taken. Maximum incidence was seen in the 4th decade of 44%. Next to it was the 5th decade to 32%, as I have already mentioned in the result. Out of the 50 cases, there was male 62% or 38% were female. Findings are consistent with the result of other study in Bangladesh. Akhtar et al. Reported that diabetes and pre-diabetes are highly prevalent among individuals aged 35 years or more in Bangladesh. Who listed 10 countries to have the highest number of people with diabetes in 2000 between 2030. According to this report, Bangladesh has 3.2 million of diabetic subjects in 2000, and the number is expected to increase in staggering to 11.1 million by 2030, placing her among the top 10 countries with diabetes. Mean age of the patient group was 43. Large number of respondents came from the urban area, that is 68%, followed by rural area, 32%. Present study shows that 26% of patients had thyroid abnormalities. Among them, 8 cases were male and 5 cases were female. Findings are according with other study findings. In a study, maximum number of type 2 diabetic patients with thyroid dysfunction belong to this age group more than 60 years. That is 19 out of 40 abnormal cases and 5 out of 9 abnormal controls. The percentage of the male-female ratio was 1.3:1. Subclinical hyperthyroidism was predominant in both sexes cases as well as controls. Our study demonstrated that majority of diabetic patients were suffering for more than 6 years, and only 12% are diabetic less than 1 year. Thyroid abnormalities associated with the duration of diabetes. The duration of diabetes here was 6.28% in patient with normal thyroid profile and 10 years in patient with abnormal thyroid profile. Mean duration of the disease was highly significant when both the patient subgroups were compared. The p-value is 0.012312. The result is statistically significant. In a study, out of the 80 type 2 diabetic subjects, study showed the abnormal thyroid function. 20% had hypothyroidism and 6% had hyperthyroidism, and 71% showed normal thyroid hormone level. The incidence of hypothyroidism was more in female as compared to male in type 2 diabetes mellitus. Hypothyroidism was present in 22.50% patient, of which 13% had subclinical hypothyroidism and 8.75% had primary hypothyroidism. The ability to diagnose and treat unsuspected hypothyroidism in type 2 diabetic patients may result in better control of the diabetic state, thereby enhancing the quality of life. The serum level of T3, T4 and free T3, T4 were significantly lower in diabetic subjects as compared to the non-diabetic subject, while the level of serum TSH was significantly higher in diabetic subjects as compared to non-diabetic subjects. This study demonstrated that 54% of subjects with normal thyroid profile in the study group had hemoglobin A1C less than 7%, in contrast to 69.23 subjects are with abnormal thyroid profile have hemoglobin A1C equal or more or equal to 8%. Findings are consistent with result of other study, that is VK et al. The prevalence of thyroid dysfunction among type 2 diabetes patient is very high, with subclinical hypothyroidism being the most common. The level of T3, T4 was significantly lower, while the level of TSH was significantly higher in type 2 diabetes as compared to non-diabetic. Another study reported that low serum T3 level in diabetic subjects as compared to the control group. The mean level of serum T3, T4, TSH level are comparable between two groups. 51% are subjects with normal thyroid profile in the study group had hemoglobin A1C less than 7%. And the mean duration of the disease was near to 6 years in patient with normal thyroid profile and 12 years in patient with abnormal thyroid profile. The mean duration of disease was highly significant when both the patient subgroups in the diabetic were compared. Present study demonstrated that prevalence of hypothyroidism is among overall thyroid dysfunction. 18% of patient hypothyroidism were present in 8% of patients. There is another journal, that is Islam et al. They investigated the thyroid hormone level in 52 uncontrolled diabetic patients and 50 controlled subjects. They reported that patients with type 2 diabetes had significantly lower serum FT4 level compared with the control study subjects. To observe disorder included, a cross-sectional study in Bangladesh shows prevalence rate of thyroid dysfunction was 10%. Female were found with higher rate of thyroid dysfunction and male were 21%. The majority of patients had diabetes for more than a 5-year duration. especially aged between 41 to 50 years, were found to be more affected with thyroid dysfunction. So here is the conclusion is there is a higher prevalence of thyroid disorder in type 2 diabetic patient. This finding is more common in diabetic female patient. The most common thyroid disorder is hypothyroidism. The association of thyroid disorder with diabetes is more frequent in diabetic who have challenged metabolic control. Thyroid also influences the hemoglobin A1C level. Thus, biochemical screening for thyroid disease is justified in diabetic patients in a view of high yield of demonstrated in this study and likelihood of symptoms of thyroid disease being masked by the diabetic state and thyroid aggravating the diabetic picture. The approach of using a screen test to explore thyroid disorder was not effective. Rather, routine screening is recommended for all type 2 diabetic patients to reduce the burden of the disease. There is some limitations of my study. This study was not without limitation. That the sample size is small. It was a single center study only done in Solimola Medical College. Study was conducted in a tertiary care hospital, which may not represent the real scenario of primary or secondary care center. Thank you. Thank you all.
Thank you, Dr. Farhana. That was an excellent presentation. Hope the participants have learned and benefited by your research work. And kindly proceed with the question.
Diabetes, hypertension, coronary heart disease, stroke, cancers, etc. are chronic diseases, do not spread from person to person, take a long time to develop, and several years or lifelong. Traditional herbal medicines are used for NCDs, are indigenous or folk medicines, comprise medical aspects of traditional knowledge with very less or no side effects comparatively. Therapeutic knowledge of Indian traditional medicines has propelled various traditional approaches which are of regional significance, granny cure like spices, herbs, vegetables, and other meant for diabetes and other NCDs are also included in the traditional medicines. Most often, non-communicable diseases originates from unhealthy lifestyles and adverse physical and social environments. Well-known risk factors including poverty, poor diets like intake of foods rich in fats, salts, and sugars, physical inactivity, consumption of tobacco, excessive use of alcohol, and stress. In India, NCDs contributes to 60% of all deaths, out of which four major causes of NCD death are coronary heart disease, stroke, and hypertension, 45%, chronic respiratory disease, 22%, cancer, 12%, diabetes, 3%, and remaining others, 18%. Objective of my study to analyze the use of traditional herbal medicines for non-communicable diseases like diabetes and hypertension and adoption of medical pluralism by diabetic and hypertension patients in rural areas. These studies, especially from the Himachal in some rural areas, this is a qualitative as well as quantitative research, which includes the case study method. The subjects are conveniently recruited at institutional level and by visiting in different selected rural areas of Himachal Pradesh in India and by questionnaire. Near about 5,400 to 5,600 investigations are done from the target population, included 947 patients suffering from non-communicable diseases like diabetes and hypertension. The tests are conducted and the data is collected from these NCD patients. The confirmation of the test has done on the basis of American Diabetic and Heart Associations and ICMR. A reason to adopt traditional herbal medicines in rural areas. Mostly medicines prescribed by prescribing agencies, and there is no uniform pattern or policy for prescription of medicines for diabetic patients or NCD patients. low economical conditions and affordability in rural areas, less knowledge of these diseases and their effects, no proper counseling, no strict policies of government for providing free treatment for diabetic and NCD patients. Some of the traditional herbal medicines used for diabetes and hypertension with their scientific names: Giloe, Dinospora cordifolia, Nilkanthi, Azuga bacteosa, roots of berberine plants, Berberis aristata, leaves and fruits of jamun, Syzygium cumini, leaves of Gandhela peripatta trees, Bulgaria, Coenigli, roots of Amla, Phalanthus emblica, garlic, Allium setium, Ashwagandha, Withania somnifera, leaves of guava, Pseudium gozava, leaves of neem plants, Azadirachta indica, haldi, curcuma longa, methi, fenugreek, trigonella, Pholinum gracium, papaya, carica papaya, leaves of Eucalyptus cinerea, bark of Arjuna, Ternelia Arjuna. Now, these are the results of the data which I collected. Investigation of the normal persons versus diseased persons, DM, HTN, to date. The total persons investigated, these persons are investigated at institutional level or in different camps from last 4 to 5 years. The total persons are 5,498. And from these investigations, normals are 4,551 and diseased with HTN and DM are 947. DM patients are 368 and hypertension patients are 579. Data of the patients with the system of treatment used. Out of these 947 patients, the patients which use the modern allopathic medicines are 571. This is 60.30%, and 156 patients used exclusively traditional herbal medicines for these NCDs. This is 16.47%, and 220 patients used both modern and herbal medicines in combinations. This is 23.23%. Now, this is the comparisons of all these patients. The modern allopathic medicines are used by DM patients, 152 patients, which is 16.05%. HTN patient, 360, 16 patients has used modern allopathic medicines, which is 33.37%. And DM with HTN patients of 103 used modern allopathic medicines, which is 10.88%. And the total modern allopathic medicine users are 571. This is 60.30%. Traditional herbal medicine users, DM patients 26.75%, whereas HTN patient, hypertension patient 106. This is 11.19%. And 24 DM, sorry, 2.53%, and the total is 156. 16.47% patients has used traditional herbal medicines. Then 35 DM patients has used both modern as well as traditional herbal medicines. This is 3.69%, and 157 patients of HTN, which is 16.58%, used both the systems, and 28 DM with HTN patients has used both system, which is 220 and 23.23% of the total used. data financial impacts of use of traditional herbal medicines on modern allopathic medicines, conventional system of treatment. Modern allopathic medicine users are 60.32%, whereas traditional herbal medicine users are 16.47%, and both users are 23.23%. The financial impacts, 39.70%, and here is 16.47%, and here is 11.62%. The total financial impact is 28% on modern allopathy system by using of these traditional herbal medicines. Total persons, this data is up to December 2023. The total persons were investigated up to then is 2,483, and the normal were 2,029, and diseased were 454, HTN2 137, DM 113, others and series 104. Then traditional herbal medicine users were 107. Modern allopathic medicine users were 140, and traditional herbal medicine as well as modern medicine users were 207. Now, the conclusion of the studies. These NCDs affects the economy of the country as well as individual negatively, and 80% of the burden can be reduced by appropriate treatment. More patients of DM and HTN have adopted modern allopathic medicines for treatment as compared to traditional herbal medicines, whereas many of these patients have adopted both systems of treatment. Total patients of DM, HTN, which use modern allopathic medicines are 60.30%, traditional medicines are 16.47%, and which have used both systems are 23.23%. Conclusion. Next, socio-culture and economic challenges to diabetic and hypertension patients increase dependency on traditional herbal medicines and also in dualistic system of medicines, traditional as well as allopathic medicines. From total person investigated, normal persons are 82.78%, whereas diseased persons are 17.22%. Out of these diseased persons, SGNs are 10.53%, DM are 3.87%, and HTM with DM are 2.82%. Financial impacts on allopathic medicines is 28.09% due to use of traditional herbal medicines. Recommendations. Appropriate fund budget for medicines in rural areas, proper counseling and guidance regarding impacts of diabetes and hypertension. Allopathic medicines have side effects, and the rural population is now much willing to take allopathic medicines and prefer to take traditional herbal medicines. There is a need to develop therapies like genetical therapies for diabetes to get rid the patients to take the heavy load of these medicines. The patients should be prescribed authentic medicines for diabetes patients, and this should be made as a right of the diabetic patients to get ethical and authentic treatment at country level or at world level. The law should be made at country level and world level for the right of the diabetic patients to get ethical treatment for diabetes, because in India, many patients are prescribed substandard medicines to these patients to get the benefit by prescribing authorities. These are the systems recommendations of American Heart Associations and for diabetes and hypertension. These are the references. These are the references from which I concerned. My topic is over.
Thank you, Dr. Naresh. That was an excellent presentation. Hope the participants have learned and benefited by sharing your research work. Kindly proceed with the question and answer session for Dr. Naresh.
correlation with HbA1c in type 2 diabetes mellitus. So all of you know type 2 diabetes is a metabolic disorder which is a multifaceted in nature, and it is related to the human body insulin resistance. And resistance to its action causes impaired glucose tolerance and hyperglycemia. So serum ferritin and C-reactive protein was an acute phase reactant, which was initially during my thesis work, during my study, it was usually done in view of COVID-19 patients. I took it as one of the indicators for the inflammatory processes which can occur in the diabetes patients. And it was always, it was correlated with the HbA1c in diagnosed diabetic patients as a chronic inflammatory markers too. So the aim of the study was to study the relationship between the HbA1c in type 2 diabetes mellitus and inflammatory markers such as serum ferritin and C-reactive protein. So the material and methods were this study group, which I did, was composed of 106 patients who were inpatient and outpatients, who were in the age group of between 30 to 90, involving both the genders, and the inclusion and exclusion criteria were added to this group. The investigations were fasting blood sugar, the postprandial blood sugar, HbA1c, urine routine, lipid profile, serum ferritin, and CRP were assessed in all the subjects. Data were statistically analyzed and compared the relationship between HbA1c and serum ferritin and CRP. So the results in this study were, I'll come to the results later on. Talking about the materials and methods, as I told you, this was conducted in the tertiary care hospital with the outpatient department and inpatient department. I could collect a sample size of 106 within a span of 1.5 years. And these patients were, according to their nutritional value, their BMI was calculated, and the inclusion criteria was patient who were diagnosed with diabetes or a newly diagnosed diabetes mellitus, and who also were taking the current therapy like hypoglycemics or insulin and OHAs, and also aged about 18 years. The exclusion criteria involves males and females HP levels less than 13 and 11, and people who have undergone anemia treatment, because anemia itself can cause serum ferritin test value, and which was previous in 2 months, and individuals with recent hepatitis or coronary artery disease, because these inflammatory markers can be raised in those conditions or diseases, and patients undergoing chemotherapy or radiation. So individuals suffering from hematological illnesses such as hemochromatosis, porphyria, leukemia, or Hodgkin's lymphoma were also evaluated, were excluded from these disorders because the serum ferritin and CRP can also be detected in those. 2 minutes. And individuals suffering from inflammatory diseases like rheumatoid arthritis and infections like
Excuse
pneumonia.
me, Dr. Nikita, your slide is not moving.
I'm not able to. 1 second, ma'am. Okay. What? Yeah. I'll be speaking about it. The slide, the slides have like 12 or 11, but I'll be orally presenting it.
Okay.
Is that fine? Yeah. So I was talking about the inclusion exclusion criteria. So we've discussed about it. Few of the conditions which can itself cause CRP and serum ferritin raise, we had excluded all the diseases such as patients undergoing a chemotherapy or a radiation, individuals suffering from hematological illnesses such as hemochromatosis, porphyria, leukemia, Hodgkin's lymphoma, and also with inflammatory disorders like rheumatoid arthritis and infections like pneumonia were excluded from these materials and methods. And we also subjected the patient to the blood investigations like HbA1c and CRP levels. So on that, next slide, please. Among that, the results in the study, 31.1% constituted Yeah. As we all know, diabetes mellitus is a non-communicable disease which is increasing in prevalence in global epidemic proportions, putting stress on the healthcare expenditure. To study the association between diabetes and inflammatory markers, serum ferritin and HbA levels were correlated. This was done in the college, as I mentioned, from the November 2020 to June 2022. Next slide. Can move the slide, please. Yeah, patient was it was a cross-sectional study which was done on 106 patients. And in our study, majority of patients were 31.1% were in 50 to 60 age group. Majority of them were males. Urine albumin is present in approximately 20%. In this study, standard deviation of HbA1c was 2.5, serum ferritin is 284, CRP being 38.57. A Spearman correlation as a statistical analysis was done, and serum ferritin and HbA1c, the R value is 0.011 and the P value is 0.99. However, C-reactive protein and HbA1c had the R value of 0.017 and P value is 0.86. However, in this study, the correlation of CRP and serum ferritin as an inflammatory marker was raised, had a positive correlation with a HbA1c, but it did not show any significant value. But however, we can tell as the HbA1c increased, we saw in the study even the serum ferritin and CRP values were increased. So it had a positive correlation. Next slide. So there
Dr.
was no
Mamata
association.
Ramesh, sorry, Nikita. Dr. Mamata Ramesh, kindly mute your audio as we are having a disturbances.
So there was no association between age, gender, and with both inflammatory markers and HbA1c levels. In type 2 diabetes centers, the mean HbA1c levels were to be higher with serum ferritin and CRP. It showed the value of inflammatory markers, which was correlating with the HbA1c levels. So there was a positive correlation. Yeah, talking about it, two and proteins like hepatocytes to play a role in insulin resistance at the cellular level are serum ferritin and C-reactive protein, which are both formed in the liver due to inflammation. So adipose tissue releases inflammatory cytokines that have an endocrine effect that results in insulin resistance in the liver, skeletal muscles, and vascular endothelial tissue, leading to the clinical manifestation of both diabetes mellitus. The cytosolic protein called ferritin is present in the majority of tissues. Ferritin as a 24 subunit protein contains the two distinct subunits types HL and HNL. So CRP is also oligomeric protein member. This is also considered to contribute to insulin resistance by inducing thrombogenic agents, activating the complement cascade, upregulating the endothelial adhesion molecules, and downregulating endothelial nitric oxide synthase. So this study was basically to prove diabetes is also a chronic inflammatory condition where the inflammatory markers of HbA1c, inflammatory markers such as serum ferritin and CRP also showed a positive correlation as the HbA1c was high. So we all know diabetes is a insulin resistance and it is also metabolic disorders. Like risk factors such as obesity, hypertension, dyslipidemia can also cause insulin resistance to be high. So like adipose tissue, when it gets activated, it also releases the cytokines and inflammatory markers like CRP and ferritin, which can be elevated in the patients of uncontrolled type 2 diabetes. So I've also spoken about material methods, inclusion and exclusion criteria, and I'll be showing few of the tables. Sorry for the inconvenience, but it is on my laptop. Are you able to see the results? Okay, so in the results, diabetic patients were distributed among age group. We found 31% were in 50 to 60 age group, whereas 23.6% were in 40 to 50, whereas the mean higher was in 40 to 50-year age group. Among males and females, there were the frequency was males were higher, belonging to 51.9%, whereas female had 48.1% of females were there out of 106 patients. So in urine, when we measured the urine sugar, urinary sugar were present in 22.6% individuals, and urine albumin was present in trace was present in 24.5%, and urine albumin was absent in 56% of patients. So on OHAs, among 106 patients, 68 were using oral hypoglycemics, whereas 64.2 were using 64.2%. That means the 68 patients were using oral hypoglycemic drugs, and 45.3%, that is 48, were on insulin. The correlation between the age and HbA1c was p-value was 0.317, and the main thing is correlation between the HbA1c and serum ferritin. R value was 0.011 according to the Pearson correlation, whereas p value was 0.911. There was a positive correlation which was found between serum ferritin and HbA1c. And along with the HbA1c correlation with CRP, there was also a R value of 0.017 and P value of 0.865. There was also a positive correlation which was found between CRP and HbA1c. So in the conclusion, what we in this study, there was a positive correlation. Raised inflammatory marker suggestive of a chronic inflammatory process which occurs in a condition or disease process such as diabetes mellitus. Measuring these values gives us a valuable information on screening, duration of diabetes, and prevention of complications. So the limitations of the study were sample size is relatively small. Any chronic inflammatory conditions would have raised values of inflammatory markers which is not specific to diabetes mellitus. So the study design was a cross-sectional, which could be confining in a causal relationship between serum ferritin, CRP, and HbA1c. Duration of diabetes is not considered in the study. So to summarize, to summarize, diabetes mellitus is a non-communicable disease which is increasing in prevalence. So which is putting stress on the healthcare expenditure. To associate between the diabetes and inflammatory markers, serum ferritin and their correlation was studied. So, so this would be one of the two markers which can be assessed as an inflammatory process which has happening in a diabetes mellitus other than the metabolic disorders. Thank you.
Thank you, Dr. Nikita. That was an excellent presentation. Hope the participants have learned and benefited by sharing your research work. So kindly proceed with the question and answer session for Dr. Nikita.
Especially in both developed and also in developing countries. Here, I have taken two main keynote to combat this threat, that is increasing blood glucose levels. And the keynotes are activation of adiponectin and increasing the leptin levels, counter-regulation of stress hormones, and inducing thermogenesis, which helps in activating the brown adipose tissues. And also it helps in converting the white adipose to brown adipose, and also stimulating the atrial natriuretic peptide. So taking these key notes into consideration, I have chosen two therapies, that is a Swedish massage given to the abdomen and also a hydrotherapeutic procedure, neutral hip bath, in order to combat this increased blood glucose levels. And also, these treatments are already proven to produce these significant effects already noted in the keynote. And also, I'm going to explain in detail about the molecular mechanisms underlying these two alternative therapies. So first, I'm going to explain about the abdomen massage. So abdomen massage is nothing but a type of a Swedish massage given to the abdominal part, so which helps in the activation of adiponectin. Okay, helps in the activation of adiponectin, increases the leptin levels, and induces thermogenesis locally at the abdomen, and also helps in the activating the BAT, brown adipose tissues. So these points were clearly given in these two research evidences. So first, coming to the leptin. So leptin, what leptin is, it's principally a adipose tissue hormone produced in the adipose tissue. But not only in adipose tissue, it is also produced in the placenta, mammary gland, ovaries, skeletal muscles, stomachs, and also in the pituitary. Especially the circulating leptin level acts indirectly proportional to the body fat. So it clearly indicates that when the body fat increases, the leptin level reduces. So deficiency of leptin level, it is directly involved in the insulin resistance and also finally resulting in the hyperglycemia. And also, on the other hand, leptin induces negative feedback signal to the adiposity. So that it gives signal to the hypothalamus to reduce the energy intake and also increase the energy expenditure. And also it activates the nutrient sensing AMPK pathway, which is very important in activating gate pathways, and also in MTAR, that is mammalian target of rapamycin signaling pathway. So coming to the next point, inducing thermogenesis, how it helps in reducing blood glucose levels is, so when locally applying massage, we always know if there is a friction, there will be a local thermogenesis created. So when abdomen massage is given for some 10 to 20 minutes, it will create automatically local thermogenesis, which will affect for nearly half an hour. So this local thermogenesis helps in activation of brown adipose. So this is also a proven mechanism already. This BAT, what it will do is this activated brown adipose, it increases the catabolism of BCCA, that is branched chain amino acids. So BCCA in turn, what it will do in the accumulation of BCCA, it will induce the insulin resistance, whereas this brown adipose tissues, it will induce the catabolism of BCCAs. So it will also help in reducing the blood glucose levels. On the other hand, this brown adipose tissues increases the fibroblast growth factor 21, FGF21, and also it increases the adiponectin levels and also leptin levels also. So this FGF21, fibroblast growth factor 21, helps in the increasing the GLUT expression and also increases the insulin sensitivity in the cells. So this is the mechanism of thermogenesis induced brown adipose tissue activation in the abdominal massage. So next one is coming to the main keynote of abdomen massage is the activation of adiponectin. What adiponectin does in abdomen massage in case of diabetes mellitus. So first one is, before going to adiponectin, we should know about the adipokinin and its mechanism behind diabetes mellitus. So adiponectin and adipokinin both are produced from the adipose tissues beneath the skin. So here, in case of obesity and metabolic syndrome, there will be infiltration of inflammatory cells in the adipose tissues automatically. So it's termed as adiposity. Obesity is termed as obesitis. In case of this time, this adipose tissues produces pro-inflammatory adipokinins. So this adipokinins helps in the production of tumor necrosing factor alpha, interleukin 6, and also monocyte chromatin protein MCP1, and also lipocalin 2 and resistant. So during prolonged increase of adipokinins in the abdominal tissues, it will directly result in insulin resistance. So whereas in case of adiponectin, it reduces the inflammatory reaction and also it reduces the production of adipokinins. So there is a huge mechanism behind adiponectin in the diabetes mellitus. In case of adiponectin, It directly inhibits the stimulation of nuclear factor Kb, which signals the TNF alpha secretions. And also it modulates the inflammatory macrophages function. So thereby it reduces the adipokinin function and reduces the inflammation in adipose tissues. On the other hand, adiponectin also stimulates the interleukin 10 and also interleukin 1 receptor antagonists. It also suppresses oxidative stress by inhibiting the inducible nitric oxide synthase INOS, and also suppressing the NADPH. So by doing this, the oxidative stress is reduced, which also helps in reducing the inflammation and inhibiting the insulin resistance. So on the other hand, it also prevents the inflammatory cytokine-induced apoptosis in cultured beta cells. Adiponectin in GLUT4 in glucose transporters. GLUT4 induces the translocation, and thereby it directly impacts on the glucose uptake in the body. So by activating AMPK, that is adenosine monophosphate activated protein kinase pathway, and PPAR pathway, so it suppresses the gluconeogenesis and glucogenolysis in the liver, and directly it inhibits the glucose level increasing in the blood by limiting the glucose 6 phosphatase enzyme. So these are the main keynote points to be noted in adiponectin mechanism. So these mechanisms are happening in the body when abdomen massage is given for 10 to 20 minutes, and it is also proven in the given paper. So next, coming to the neutral hip bath. So this is another alternative therapy modality I have chosen. That hip bath is a tub where we will be filling water up to a certain mark, and patient will be made to sit inside that for 15 to 20 minutes. And the temperature in which the water is given defines the therapeutic effect we are desiring. So here I have chosen neutral hip bath in order that I want some sedative effect. So I have chosen that I have given priority to psychological stress more other than the oxidative stress, because in case of psychological stress, patient experience more type of diseases other comparatively to the oxidative stress. So both are equally important, and in case of sedation, if we are giving, automatically the psychological stress will be reducing. So whenever we are giving a neutral temperature, there will be a desired sedative effect. So neutral hip bath for 15 to 20 minutes gives a sedative effect, and which counter regulates the stress hormone. And also it stimulates atrial natriuretic peptide, and also this also activates the activating brown adipose tissues. So during sitting in the hip bath, we used to give a friction in the abdomen for 15 to 20 minutes. This also gives a kind of frictional massage to the patient. So these mechanisms are explained and proven in these two research evidences. Coming to the psychological stress in case of diabetes mellitus, it increases nearly 60% of the condition. It worsens also this condition of the diabetes patients. And especially the stress hormones like cortisol, epinephrine, and growth hormones, these are glucose counter regulating hormones. They directly act on the liver, producing the glucogenolysis, and also increases the fat breakdown, resulting in increased sugar levels and also fatty acid ketone bodies in the blood. So that this cortisol and growth hormone, they directly induces insulin resistance in the skeletal muscles. Through this HP axis triggering, we can reduce the psychological stress, and also reduce the sympathetic nervous activity. That way we can revert back the type 2 diabetes and also control the blood glucose levels. So coming to the brown adipose tissues, we have already mentioned that brown adipose, by catabolizing BCCS and also fibroblast growth factors, it increases the GLUT expression, and it helps in glucose uptake, and also it reduces the blood glucose levels. So coming to the atrial natriuretic peptide, so these are produced in the cardiac muscles. This increases the insulin levels by 50%. So this atrial natriuretic peptide, it helps both in type 1 and also in type 2 diabetic cases. So this in other hand, it reduces the sodium resorption and also reduces the blood pressure. So it can be used as a mode of therapy in case of metabolic syndrome also. It also, in the other hand, reduces the SNS activity, sympathetic nervous system activity, and also it increases directly the adiponectin levels. So it manages the mitochondrial uncoupling during the energy production. So the energy expenditure is increased, so that it also helps in controlling our diabetic case. So it the another way where it helps, it directly whitens the browns the white adipose tissue. That is also another choice of where it helps to make it an other choice of treatment. So by taking all these notes into consideration, we have taken these two treatments, that is the abdomen massage and neutral hip bath, as an integrated approach towards treating the diabetes. So we have taken 100 individuals in our study, and we have done randomization and grouped into two groups, group 1 and group 2, and the case group is group 1 and case control group is group 2. In case group, we have given abdomen massage with neutral hip bath as an integrated approach, along with the normal naturopathic treatments and the regular medications what they are taking. Along with them, we have introduced this regularly for 10 days. Whereas control group, they have not given any mode of extra treatments other than their regular medications. After assessing pre and post assessments for 10 days, these were the results we have got. That is, both the groups had a significant reduction of blood glucose levels, both fasting and postprandial, in the pre and post levels. But comparatively, the group, those who have taken the abdomen massage and neutral hip bath, have had reduction in their blood glucose level drastically when compared to the control group. And also the another keynote what we should take here is the hip waist ratio was significantly reduced only in the case group, those who have taken abdomen massage and hip bath, and not in the control group. So by this, we can directly see that the case group, those who have given this massage and hip bath for regularly for 10 days, have significant reduction in the abdomen hip waist ratio. That is, the abdomen fat, it started reducing after this massage, which directly has impact on the blood glucose levels. So this was a study, and this was the mechanism behind a study. So by this, I'm concluding that not only relying on a single medicine, integrated approach is also has a beneficial effect, and also it have some effect on reducing the stress and patient's satiety level. Okay. Thank you for the opportunity, and by this, I'm concluding my topic.
Thank you, Dr. Helia. That was a very excellent presentation. Hope the participants have learned and benefited by sharing your research work. Kindly proceed with the question and answer session for Dr. Helia.
Heart rate, oxygen saturation, respiratory rate, and body temperature. Spirometry measures blood pressure of one side of arm at one time. Consists of an inflatable cuff to clamps tied about 2 to 3 centimeter above elbow. Instrument is put on level of chest and then release the artery under cuff in a controlled manner. 0 to 30 mmHg or more variation of blood pressure and pulse rate occurs in human beings in interarms. Blood pressure of normal adult is approximately 120 on 80 mmHg and pulse rate is 70 to 80 per minute. Blood pressure variation and pulse variation represent a strong and independent risk factor for cardiovascular disease, and it also represents the hypertension-related mortality and morbidity. Blood pressure and pulse rate variation may lead to misdiagnosis of hypertension, which can be prevented by measuring the blood pressure and pulse rate interarms. Objective of the study to detect the interarm variation in systolic and diastolic blood pressure and pulse variations with its management. Research methodology. This is qualitative as well as quantitative research, which includes the case study method. The subjects are conveniently recruited at institutional level and by visiting in a different selected rural areas of Himachal Pradesh in India, and by some questionnaires sent to the recruited patients through WhatsApp or through email. 5,400 to 5,600 investigations are done from the target population, includes 947 patients suffering from diabetes, hypertension. The tests are conducted and the data is collected from these patients. The confirmation of the tests has done on the basis of parameters given by American Diabetic and Heart Associations and ICMR. Sphygmomanometer is used to measure blood pressure and pulse rate of both arms turn by turn or simultaneously by using two sphygmomanometers. Thrice concordant readings are considered and noted for this purpose of blood pressure and pulse rate in persons of different age group, and average real variability method is also used to estimate blood pressure and pulse variation. This is the data of the diabetic and hypertension patients. The total persons are investigated from 4 to 5 years are 5,498, and normal persons are 4,551, and diseased with HT and DM, hypertension, diabetic mellitus, and hypertension with DM are 947, and hypertension patients are 579, and diabetic mellitus patients are 213, and the HTN with diabetic mellitus are 155. And the percentage of normal person is 82.78%, whereas diseased persons are 17.22%. The HTN patients are 10.53%, diabetic mellitus patients are 3.87%, and HTN with DM are 2.82%. This is the data of variation of the systolic, diastolic blood pressures and pulse variations. The total persons of different age groups are investigated are 5,498. Out of these patients, males are 2,629, which are 47.82%, whereas females are 2,869, which are 52.818%. The systolic blood variations in the patients and the persons in 0 to 10 mm Hg points variations are 3,895 patients have systolic blood variations, which is 70.84%, and the diastolic blood variations is 4,847%, which is 0 to 10 mm Hg points variation, which is 88.16%, and the pulse variation is in 4,997 patients, which is 90.89%, have 0 to 10 mm Hg points variations. And the persons which have 11 to 20 mm Hg points variations, systolic blood pressure variation is in 1,178 patients, which is 21.42%, and in diastolic blood pressure variation in 393 patients, which is 7.14%. This is 11 to 20 mm Hg point variation, and pulse variation, which is 11 to 20 mm Hg point variation. This is 312, which is 5.68%, and the person in 21 to 30 mm Hg points variation in systolic are 362, which is 6.59%, and diastolic blood variation is 202, which is 3.68%, and pulse variation is 135, which is 2.45%. And person who are 30 more than 30 Hg variations, and the systolic variation is 63, which is 1.15%. Diastolic variation is 56, which is 1.02%, and pulse variation is in 54 patients, which is 0.98%. Then the total disease persons which are suffering with HTN and DM are 947, which is 17.22%, and normal person are 4,551, which is 82.78%. Next slides, please. Now, this is the measurement of in different age groups from 18 to 100 years of patients. In first, in the age group of 18 to 40 years, the total person investigated are 1,634, which have normal, from those normal are 1,596, and the persons which are suffering with HTN, DM, with HTN, with DM are 38. Total are 38, and out of those 38, DM patients are 14, HTN patients are 21, and HTN with DM patients are 3. In the age group 41 to 60, total investigations are done 2,098. Out of these 2,098, 1,688 are normal, and 410 are diseased. Out of these 410, 124 are suffering with DM, and 222 are suffering with hypertension, and 57 are suffering with hypertension and diabetic mellitus both. In the age group 61 to 80, total investigations are done 1,682. Out of these 1,682, 1,210 are normal, and 472 are suffer with HTN, DM, and HTN with DM. Out of these 472, 62 are diabetic patients, and 313 are hypertensive patients, and 91 are hypertension with diabetes mellitus. And in the age group of 81 to 100, only 84 patients are investigated. Out of these 81s, 57s are normal, and 27 are suffering with hypertension, DM, and HTN with DM. Out of these 27, 7s are diabetic patients, 16s are hypertensive patients, and 4 are hypertension with diabetes. The total patients investigated, total persons investigated are 5,498. Out of these, 4,551s are normal, and 947s are diseased, and 213s are suffering with diabetes. 579s are HTN, and 155s are diabetes with HTN. Next slide. Next slide. Conclusion. The variation in blood pressure and pulse rate in interarms is observed in different age groups, which from 0 to 10 mmHg to 21 to 30 mmHg or more. More variations may show on the cardiovascular diseases in individuals. 82.78% persons are normal, whereas 17.22 persons are suffering with hypertension and diabetes. The variation in systolic and diastolic blood pressure is maximum in the range from 0 to 10 points mmHg, whereas minimum above 10 is this variation. It is recommended that 5 micrometer. There is some recommendations and management for this. It is recommended that 5 micrometer meter should be made for measurement of the blood pressures of interarms. On the same time, to avoid the error of variation of blood pressures and pulse rate, the accuracy of the readings is detected. The apparatus may have two cuffs to tie both sides of arms and should be attached to a single instrument. The readings of blood pressure and pulse on the monitor should be different for both arms with one conclusive reading on the screen. The conclusive reading of blood pressure and pulse rate should be considered for the diagnosis of for hypertension or hypotension. There is need of amendments in the existing 5 magnetometers. In case of digital automatic blood pressure instruments, the readings may be detected on the monitor easily. But in case of non-digital instruments where stethoscope is requisite for the measurement of the blood pressure, problem may be arisen to manage the measurement of the blood pressure by using the cuff in both the arms, but this instrument can also be amended. Concordant readings of blood pressure and are considered for of interarms to avoid the misdiagnosis. Coefficient of variation is another method, which is the standard deviation divided by the corresponding mean. Next. The results of 24-hour ambulatory blood pressure monitoring are considered to avoid blood pressure variations with the intentions to quantify the extreme of blood pressure excursions to calculate the difference between maximum and minimum blood pressure values, which has the advantage of being independent from the mean. Further studies of measurement and implications of an interarm difference are needed. The effect of the full protocol is reducing current prevalence suggests that future epidemiological studies of interarm differences must adopt a similar, robust, repeated simultaneous measurements approach to avoid overestimation of prevalence. These are the slides of the parameters on the behalf of which I detected the range of the blood pressure. Please next. Next. This is also the slide of the ICMR parameter to detect the hypertension grade 1, grade 2, and grade 3. This is the range given in the ICMR list for hypertensive stages, different hypertensive stages or grades. Next slide, please. These are the references from where I saw this topic. Next. These all are the references. Next, please. Next. Now, next. Thanks. Now this topic is over.
Thank you, Dr. Naresh. That was an excellent presentation. Hope the participants must have learned and benefited by your research work. Kindly proceed with the question and answer session.
Am I audible, ma'am?
Yeah, you're audible.
My screen is display is open. Hello everyone. My topic is association between serum ferritin and insulin resistance markers with distinct glycemic profiles in adult Bangladeshi cross-sectional study. So, so why this topic is so important? We know as a previous discussion, and we also know that diabetic mellitus is one of the most common non-communicable disease globally. And as if we see the data, we can see that in the list, in Asian countries, in China and India hold first and second position in case of diabetic patient, and respectively they hold 114 and 73 million diabetes patients. And in case of Bangladesh, there is no not population level study, but it is estimated that about 6 million people are suffering in diabetes mellitus. And among four type of diabetes mellitus, type 2 diabetes mellitus is most constituent about 90% of all diabetes. So our main concern in type 2 diabetes mellitus. And as a low income countries and poor countries, Bangladesh has experienced a severe burden of diabetes mellitus, and the prevalence rate is 6.8%. And Bangladesh is one of the top 10 countries with highest number of people living with diabetes. And the sad thing is that the around 56% of type 2 diabetes mellitus cases are undiagnosed in our country. According to International Diabetic Federation 2017, there is, if one patient is diagnosed, there is always one that is undiagnosed case. So you can think the horrible condition of our country. And though the patients are not diagnosed, so when they first time approach in a healthcare center or hospital, they already develop complications. And we know the macrovascular complication often arise before the type 2 diabetes mellitus manifest. And the evolution of insulin resistance to type 2 diabetes mellitus has led to increased health system cost worldwide. These costs are mainly due to complications. And we find that 50% of the currently undiagnosed population of our country, that is 3.8 million, that is 35 plus years, the cost would be about 9.5 million. So what is the etiological cause of this type 2 diabetes mellitus? We know there is two main culprits, that is insulin resistance and beta cell dysfunction. This is our core component of type 2 diabetes mellitus. Our study was what is the relationship of type 2 diabetes mellitus with insulin resistance, and how can iron stores affect this relationship. So what is the nature of this association? And we know there are so many causes of insulin resistance, that is some genetic factor, environmental factor, but how can iron affect this insulin resistance and developing type 2 diabetes mellitus? Evidence suggests that there is relationship between iron store and type 2 diabetes mellitus, especially in Western countries. But in Asian population, especially Southeast Asian, this relationship is need to be established between developing insulin resistance by ferritin and then after type 2 diabetes mellitus. We know the serum ferritin, it is a iron store marker. It is widely used biomarker in epidemiological studies, and it is also act as a acute phase reactant. So when due to different cause, increase intake or genetic factor or other cause, our body increase iron store, so that ultimately creates free fatty acid oxidation, interference with glucose disposal in fat and adipose muscle, and it also causes decreased insulin secretion from beta cell and decreased insulin extraction from insulin. all that ultimately there is an oxidative stress created by oxygen reductive species production. So insulin resistance developed, and that ultimately developed increased hepatic glucose output and decreased peripheral glucose uptake that results type 2 diabetes mellitus. So there is a relationship, but it is not established in our population. So so here we assess elevated serum. Here we want to say what is the relationship between these markers. And here we use insulin resistance markers. Actually, we got it from a Japanese study. Here we found that insulin resistance markers included 3 variables. That is serum glucose, serum insulin, and HOMA-IR. That is homeostatic model assessment for insulin resistance. So study shows positive correlation between serum ferritin and individuals at risk of developing diabetes as well as patients with type 2 diabetes mellitus. But there is relationship, but the findings is inconsistent across different population based on ethnicity, gender, and glycemic status. Some studies said that, like a Korean study said that there is a relationship between ferritin and insulin resistance, but that only on male population, not female. But other studies showed that there is relationship on female, but not male. Some studies said that the strength and direction of this relationship is based on glycemic state. But there is no conclusive finding in our population. We find some studies that shows relationship ferritin with HbA1c, but what is the relationship with glycemic state or gender? It is not established. So for the first time here, we evaluated the relationship between body iron stores and insulin resistance markers in Bangladeshi adult population. So what our objectives are? To assess the relationship of ferritin with insulin resistance markers in adult subject of Bangladesh, to compare serum ferritin, insulin, and HOMA-IR in between newly detected diabetic, impaired fasting, and normoglycemic subjects, and to evaluate the correlation between elevated ferritin and insulin resistance markers in study subjects, and to explore, and is there any gender variation? Sorry. It was a cross-sectional analytical study. The study was done in Sir Solimullah Medical College and outpatient department of medicine and endocrinology of Mitford Hospital, and also in biochemistry and molecular biology department, BSMU, Dhaka. Our study population was divided into 3 categories. First, group A, individuals with normal fasting glucose. Group B, individuals with impaired fasting glucose. And group C, individuals with newly diagnosed type 2 diabetes mellitus. Actually, we excluded the patients who are already non-diabetic mellitus or taking a medication. This sampling was purposive convenient sampling. A total of 140 subjects are included to conduct this study. Our adult age was 25 to 55 years of age. Both gender are included. Patients are excluded by some criteria, like patients are suffering any inflammatory disease, liver disease, cardiovascular disease, anemia, or serum ferritin level is so high, or recent history of blood transfusion or iron therapy. Patients also affecting who are taking medication that affecting carbohydrate, lipid, or insulin metabolism, and the patient's C-reactive protein is more than 5 milligram per liter. Malignancy, pregnancy are also excluded. We know C-reactive protein also an acute phase reacted, so whose ferritin C-reactive protein level is high, we excluded that participant. So what we got our results in, we see the mean ferritin concentration in among 3 groups indicates a highly significant differences among 3 groups. Here we see the mean ferritin concentration in normal fasting glucose people is only 40.5. In IFG group, it is 84.4. And in type 2 diabetes mellitus, it is newly detected type 2 diabetes mellitus, the mean ferritin concentration was 158. When we comparison these 3 groups by ANOVA, we found out that in case of fasting plasma glucose is seen, that is in fasting plasma glucose. It is normal fasting group A, that's people are normal fasting glucose. Their average fasting blood glucose was 5.14. The impaired fasting glucose, their blood glucose level was 6.26, and those patients are type 2 diabetes mellitus. Their fasting plasma glucose was 9.69. And in case of insulin, and if we see the ferritin level in normal fasting glucose, that is low, but in type 2 diabetes mellitus, the average ferritin level is so high. So these both all variables, fasting plasma glucose, insulin, HOMA, ferritin, all significant differences we observed across the groups, and with elevated in group C, a type 2 diabetes mellitus group, compared to normal fasting glucose and impaired fasting glucose. This this provided bar chart display the percentage distribution of participants in 3 tertiles. The tertiles ranges are given here, and we see in normal fasting glucose, in tertile 1 ranges, 46.7% people are participant are in the tertile 1, and only 18.3% in highest tertile, that is ferritin concentration in highest tertile. And in IFG group, we see 48% people in type 2, 48% people in highest tertile. And if you see the type 2 diabetes mellitus, those are newly detected diabetes mellitus. Here we see there is no patients in tertile 1 level, and maximum 86.7% people are belong to high tertile. That is, a significant portion are in high tertile, reflecting a marked increase in type 2 diabetes mellitus compared to IFG and NFG. This percentage is actually serum ferritin percentage. And this another graphical presentation. Here we see the insulin resistance HOMA relationship between HOMA IR and serum ferritin level in both gender, and we found that in case of male, serum ferritin is positively and significantly correlated with HOMA IR. Homeostasis model assessment of insulin resistance. Insulin resistance is measured by this. And in case of female, the relationship is not significantly correlated. We know our participants are aged 25 to 55 years of age, that is reproductive age, and makes our female participants are maximum administrating age, so their iron store is less. But we got some patients, the number was few, they were post-menopausal age, and their iron store was high like a male. But in reproductive age female, the concentration was low, that is not correlated. So our conclusion is elevated serum ferritin levels in IFG and type 2 diabetes mellitus indicate a role in glucose regulation and insulin resistance. Insulin resistance markers are notably higher in type 2 diabetes mellitus and IFG, indicating important implications for disease management and prognosis. In Bangladeshi men, ferritin was positively associated with insulin resistance markers, but this relationship was not observed in women. We know Bangladesh is a low-income country, and our health sector health sector staffs are shortened. So if we create a screening measure in the primary health care before developing type 2 diabetes mellitus, if we diagnose hyperferritinemia in early stage, by that we can prevent to develop the disease or complication that will minimize our cost. And if we previously diagnose this screening measure to previously identify the patient is going to develop diabetes mellitus or metabolic disease or other disease, then we can prevent it by lifestyle modification and medication. So monitoring ferritin levels could aid in early identification of insulin resistance, ultimately development of diabetes mellitus. So it's my presentation. Thank you. This child is my lifeline. I've already said. Thank you all.
Thank you, Dr. Tasneem. That was an excellent presentation. Hope the participants have learned and benefited by sharing your research work. Kindly proceed with the question and answer session for Dr. Tasneem.
As you choose me as a speaker in this prestigious Global Summit of Diabetology and Endocrinology. I am Dr. Mohammad Farad Hassan Chaudhuri, working as Assistant Professor of Nephrology in Mugda Medical College Hospital, Dhaka, Bangladesh. Mugda Medical College is a government hospital situated in the capital of Bangladesh, Dhaka. And I am now sharing my case report. The title is Diabetic Myonecrosis involving both lower limb in hemodialysis patient, a rare complication of diabetes. This window. Sorry, there is a technical problem. Okay, this. Now, introduction. Diabetes mellitus is associated with microvascular and macrovascular complication like diabetic nephropathy, retinopathy, neuropathy, coronary artery disease, stroke, peripheral vascular disease. But less well-known complications are equally important for diagnosis and treatment to decrease morbidity like diabetic encephalopathy, diabetic cardiomyopathy, diabetic myonecrosis, infertility, periodontal disease, etc. Diabetic myonecrosis, also known as diabetic muscle infarction, causes spontaneous ischemic necrosis of skeletal muscle, most commonly in the thigh or calf. Diabetic myonecrosis is usually unilateral and affects the lower limbs. The first case of diabetic myonecrosis was described as tumoriform focal muscular degeneration in 1965 by Angerville and Steiner. They reported two patients. Both underwent excision of a painful swelling in the proximal part of lower limbs, which showed ischemic muscular necrosis. Since then, around 200 cases have been described. It has been reported in both type 1 and type 2 diabetes. Concomitant diabetic nephropathy is present in more than 50% cases. Now our patient, a 45-year-old male, presented to emergency department with painful right thigh swelling for 3 weeks. He has type 2 diabetes mellitus for more than 10 years, hypertension for 1 year, and distress renal disease on hemodialysis for 1 month. He complained redness and swelling of his right thigh and described his thigh pain as constant, aching, stabbing pain in the right posterior lateral mid-thigh with radiation distal to the calf. He denied any trauma or falls and reported worsening of pain with weight bearing and ambulation. With these complaints, he admitted in a specialized hospital abroad and initially diagnosed as cellulitis of right thigh and treated with intravenous antibiotics and analgesic. X-ray of right thigh, knee, and lumbar spine, venous Doppler of the right lower extremity were normal. As improvement of his condition was not satisfactory, MRI of both thigh done. MRI of right thigh showed diffuse intra and intermuscular fluid collection seen extending from the upper third of the right thigh down to the knee region, replacing quadriceps muscle group mainly with diffuse interstitial edema in the periosseous, inter and intramuscular plane, and commented about possibilities of diabetic myonecrosis. MRI of left thigh showed similar yet much less appreciated changes. After 15 days, with some improvement of right thigh, patient complained of pain in left thigh. The patient discharged and patient returned to Bangladesh and admitted in Mugda Medical College Hospital, Dhaka. On admission, he was febrile with a pulse rate of 90 beats per minute and blood pressure 130/90 millimeter mercury. He had a swollen left thigh, tender to palpation. The overlying skin was indurated on palpation with erythema and warmth with no evidence of discharge. Active and passive movements at the left hip and knee were limited due to pain. Lower extremity pulses were palpable bilaterally. Laboratory studies were remarkable for leukocytosis, severe anemia, elevated creatine kinase, increased C-reactive protein, and raised ESR. Additionally, poor glycemic control was confirmed with random blood glucose of 18 millimole per liter and hemoglobin A1C 10.8%. Serology was negative for HIV and hepatitis B and C. Altogether, with this finding, previous MRI report and treatment history, a diagnosis of diabetic myonecrosis of left thigh was made. Patient condition improved with analgesic, with optimization of glycemia, regular thrice-weekly hemodialysis by a jugular venous catheter. This is the discharge summary from a specialized hospital abroad. And first patient was diagnosed as cellulitis, then MRI was done, and there is a clue for diabetic myonecrosis. Now discussion. A systematic analysis of available literature showed diabetic myonecrosis was found in 54% in women, 50% had type 2 diabetes mellitus. Mean age of presentation was 44.6 years. Mean duration of diabetes at the time of diabetic myonecrosis diagnosis was 18.9 years of type 1 diabetes and 11 years for type 2 diabetes mellitus. There was a preponderance of patients with other microvascular complication, commonly renal failure, reflecting poor glycemic control. Diabetic myonecrosis is usually unilateral and affects the lower limb. The most commonly affected muscles are quadriceps, hip adductors, and hamstring. Young and Co in their study showed the muscle group affected in diabetic and distress renal disease patient on hemodialysis were thigh in 82%, calves in 11%, and upper limbs in 7% respectively. In our patient, both thigh muscle were affected. Bilateral limb involvement is uncommon. Bilateral involvement only has been reported in 8.4% cases. Regarding diagnosis of diabetic myonecrosis, routine laboratory investigation are relatively non-specific. There may be leukocytosis and serum creatine kinase levels may remain normal or slightly elevated. MRI is the most sensitive diagnostic modality, and in the appropriate clinical setting, muscle biopsy is not required. The characteristics MRI feature is an increased signal from the affected muscle area, intramuscular and perimuscular tissue. Isointense or hypointense areas on T1 weighted images secondary to increased water content from edema and inflammatory changes that accompany the infarction. In our patient, there was leukocytosis, raised creatine kinase, increased ESR and CRP with characteristics MRI changes like diffuse intra and intermuscular fluid collection extending from upper third of the right thigh down to the knee region, replacing quadriceps muscle group mainly with diffuse interstitial edema in the periosseous inter and intramuscular plane, which supports the diagnosis of diabetic myonecrosis. The most accurate diagnostic modality of diabetic myonecrosis is by tissue biopsy. On biopsy, it is found it is grossly appeared as non-hemorrhagic pale muscle tissue. Histologically, there are large areas of muscle necrosis and edema, phagocytosis of necrotic muscle fibers, granular tissue, and collagen. As renal biopsies are more hazardous in hemodialysis patients as they got regular heparin during dialysis procedure, muscle biopsy was not done in our case. Muscle biopsy is usually not done regularly in diabetic myonecrosis as it is associated with poor wound healing and higher risk of infection, seroma, and hematoma. Therefore, currently it is recommended to make the diagnosis of diabetic necrosis on the basis of clinical presentation and radiological finding. Open muscle biopsy should be limited to atypical case only. Treatment is conservative with supportive measures aimed at pain control with analgesic along with maintaining target glycemic control. Non-weight bearing activity and physical rehabilitation may be useful after the acute phase. Those who underwent surgery had an average recovery period of 13 weeks compared to 5.5 weeks for those only received conservative treatment. Our patient was treated with regular thrice-weekly hemodialysis with adequate control of diabetes mellitus, bed rest, and paracetamol. 6 weeks after initial presentation, patient condition improved markedly. Although diabetic myonecrosis has a good prognosis, it is an indicator of poor long-term outcome. However, recurrence rates are reported to be high, 40%, with a 2-year mortality rate of 10%. Now, conclusion, diabetic myonecrosis is a rare and underreported complication of long-standing poorly controlled diabetes mellitus. It can occur in diabetic renal patients with or without hemodialysis. However, the recurrence rate remains high and long-term prognosis is poor. Awareness and early diagnosis of this condition will help to improve treatment, patient care, and prevent unnecessary invasive intervention or antibiotics. So the summary and take-home message is diabetic myonecrosis is a rare complication of diabetes mellitus. Diabetic kidney disease is a risk factor for diabetic myonecrosis. Although muscle biopsy is standard for myonecrosis, but in hemodialysis patient, it is not done due to more complication. MRI with classical sign symptom can diagnose the disease. Conservative treatment and diabetes management and kidney disease treatment can control the condition. And optimum glycemic control is key to prevent recurrence. These are reference. Thank you. Thank you, madam, and thank you all the faculties.
Thank you, Dr. Farhat. That was a very interesting case study. Hope the participants have learned and benefited by sharing your study work. Kindly proceed with the question and answer session for Dr. Farhad.
But it is rising in Eastern Europe and Asia. Heart attacks are mainly caused by blockage that prevents blood from flowing to the heart. The most important behavioral risk factor of heart disease are unhealthy diet, physical activity, tobacco use, harmful use of alcohol. The effects of behavioral risk factors may show up in individuals as raised blood pressure, raised blood glucose, raised blood lipids, overweight, and obesity. It is estimated that 90% of the heart disease is preventable. Symptoms of heart attack include pain or discomfort in the center of the chest, pain or discomfort in the arms, left shoulder, elbows, jaws, and back. Heart disease are the leading cause of death globally. Bangladesh have higher CAD mortality and higher stroke mortality than Europe. In Bangladesh Army, non-communicable disease or lifestyle disease are alarmingly showing an upward trend. Bangladesh Army is always at risk due to unavoidable stress of Army life. In 2016, total death cases in Army were 64, or 31% cases were resulted from cardiovascular disease. The study was intended to ascertain the awareness on heart disease among the Army persons with a view to reduce the incidence of sudden death. Few perspectives were considered, like the knowledge about cause, signs and symptoms, risk factors, prevention and control of heart disease, and other associated factors, association of awareness of heart disease with age, length of service, rank, level of education, etc. also considered. Now, the materials and methods. Persons serving in different training centers and school under RDOC, units of 19th Infantry Division, Battle Group of RDOC, and Headquarter RDOC, irrespective of sex and rank, below Colonel were the study population. It was a descriptive cross-sectional study where the study area was selected purposefully for the research. The study was conducted in a period of 6 months, starting from February 2017 to July 2017. 242 persons were interviewed face-to-face by using semi-structured questionnaire. After collection of data, they were checked, verified, and edited, and then tabulated. Statistical analysis were done by SPSS version 20.0. The level of awareness on heart disease was assumed by arbitrarily given a score, 1 for yes and 0 for no, according to Common Medical Index, CMI. The respondents' awareness on heart disease was categorized as good level, score more than 80%, fair level, score more than 50%, and less than 80%, and poor level was less than 50%. The total score was 242. Now the result of the research. The age of the respondents were 36 plus minus 8.5 years, ranging from less than 25 years to more than 50 years. Highest number, 65, that is 26.9% of the respondents were in age group 40 to 45 years, followed by 46, that is 19.2% in age group 35 to 40. Out of 242, respondents with the age group of 40 to 45 years, 40%, 45 to 50 years, 20%, 35 to 40 years, 20%, 30 to 35 years, 14%, 25 to 30 years, 7%, respectively, found to have good knowledge on heart disease. Out of 242 respondents, about 62%, 42%, 31%, 11.5%, 10%, and 2% could correctly mention that chest pain, shortness of breath, sweating, radiating pain in jaw and extremity, and snoring, sleep apnea, respectively, are the sign and symptom of heart disease, whereas the remaining respondents had no knowledge on sign and symptoms of heart disease. So among the respondents, SSC, HSC qualified were found to be almost equal, that is 36.4% and 32.6%, while the percentage of graduate, postgraduate, and class 8 pass were 18.6%, 6.2%, 5.4%, others 0.8% respectively. Among the respondents, HSC, that is 33%, graduates 26%, SSC 20%, postgraduate 13%, and class 8%, respectively found to have good knowledge on heart disease, whereas others having various education level are found to have fair and poor knowledge on heart disease. Now, out of 242 respondents, 42, that is 17.4%, 5, that is 2.1%, 44, 18.2%, 54, that is 22.30%, 109, 45%, 108, 44.6%, 136, that is 56.2%, 50, that is 20.7%, 3, that is 1.2%, could correctly mention that age, sex, family history, diabetes mellitus, obesity, sedentary lifestyle, tobacco smoking, high cholesterol are the contributory factors respectively, whereas the remaining number of the respondents could not correctly mention the cause of heart disease. Hello, are you with me? Hello?
Yeah,
Hello.
Dr. Sheikh, continue.
Okay, thank you. Out of 242 respondents, highest number was 61%, 61, that is 25% from the rank of soldier, followed by 42, that is 17.4%, 40, that is 16.5%, 30, that is 12.3%, 20, 18.8.3%, 19, that is 7.8%, 11, that is 4.5%, 6, that is 2.4%, 5, that is 2.1%, 4, that is 1.6%, 2, that is 0.8%, 1, that is 0.4% from sergeant, warrant officer, major, senior warrant officer, corporal, lance corporal, captain, colonel, master of warrant officer, and lieutenant, respectively. Data were expressed as frequency and percentage. P-value reached from chi-square test, significant, good, and fair level of knowledge, major, poor level of knowledge, soldier, as per the table. Association of knowledge on cause of heart disease in different rank. Out of 242 respondents, 138, that is 57%, 63, that is 26%, 146, that is 60.3%, could correctly mention that diet control, drug, and regular exercise, respectively, are the contributory factors in controlling diabetes mellitus, whereas the remaining number of the respondents could correctly mention that the contributory factor to control diabetes mellitus. Knowledge and control of diabetes mellitus. Respondents having 10 to 15 years of service mostly had good level of knowledge about factors affecting heart disease. Fear and poor level of knowledge was found mostly in 10 to 20 to 25 years of long service holders. Association of knowledge on risk factors of the disease and duration of service. So, knowledge on risk factor of heart disease shown as age. Now, discussion. The respondents are exposed to strenuous duties and heavy physical exercise while providing training to the military students, and at the same time, they were involved in overall management of difficulties faced by the cadets, training officers, newly appointed recruits. During heavy physical activity, the trainees are susceptible to develop various health-related problems, which sometimes turns into fatal incidents and affects the morale of the troops. The members of Bangladesh Army belong to different socio-economic disease according to their family background found in this study. Out of 242 respondents, 47 are officers of different ranks, 60 junior commissioned officers, 61 non-commissioned officers, 72 lance corporal and Sainik participated in this subject survey. In 2016, there are few fatal incidents took place in school Chittagong, where two failed, which created a panic among the army personnel. Due to some other similar fatal incidents, the present study on awareness about heart disease, it is obvious that increased lethal outcome of heart disease. To assess and determine the level of awareness among the army persons, few parameters have been considered like age, arms, services, rank, duration of service of the individual, level of education, knowledge on risk factor, especially knowledge on cause, sign and symptoms of heart disease. The mean age of the respondents are 36 plus minus 8.5 years, ranging from less than 25 years to 50 years. The educational level of the respondents in this study were found to be ranged from class 8 pass to postgraduate, which is almost similar to the findings of the study conducted by Angosta Eddy et al. The age difference of the respondents of these two studies may be due to specific entry of age in Bangladesh Army and also the racial variation between the two study population. In this study, it was evident that majority of the respondents had poor knowledge on cause of heart disease, while mentioning age, sex, family history, diabetes mellitus, sedentary lifestyle, obesity as contributing factors to heart disease, while fair knowledge on tobacco smoking and high blood cholesterol level as cause of heart disease. Out of 242 respondents, 42, 5, 44, 54, on 09, on 08, 50, family history, diabetes mellitus, obesity, sedentary lifestyle, tobacco smoking, high cholesterol level are the contributory factors respectively, whereas the remaining number of the respondents could not correctly mention the cause of heart disease. It was found that 66.5% and 59.5% of the respondents had fair knowledge on hypertension, and respondents was found to have of heart disease. It was also evident from the present study that 62% of the respondents mentioned correctly chest pain as the symptoms of heart disease, while the rest of the respondents could not mention the sign and symptoms of heart disease correctly. In a similar study conducted by Khan S. and S. Elisa revealed low levels of awareness on heart disease and associated risk factors in Emirates women only. Awareness level was highest in Dubai among all the Emirates and 18 to 45 years of age group. Emirati women clearly lack the knowledge on severely and vulnerability to the heart disease in the region that is essential to improve cardiovascular related heart disease. It was also evident from the present study that good level of knowledge is associated with age range from 40 to 45 years having SSC level education. In a similar study conducted by Awad and Al-Nasif is among the citizens found that the knowledge on risk factors of heart disease among Kuwaiti citizens is moderate. The commonest fact participants were smoking, obesity, unhealthy diet. Was found that out of 242 respondents, 57%, 60.3% had fair knowledge on control of diabetes mellitus by diet control and regular exercise, whereas 26% had poor knowledge on control of diabetes mellitus. In a similar study conducted by Mohammad N.B. et al. In Malaysia showed that 100 respondents, only 38% could mention that diabetes is a risk factor for heart disease or cardiovascular disease. The fact behind the difference may be due to continuous health education among the persons of Bangladesh Army as prevailed. In the present study, the level of awareness on heart disease among the persons of Bangladesh Army in a good state among the officers, whereas fair and poor state prevailing mostly among the troops, which need to be improved by taking adequate effort, especially by adopting health education, motivation, and supervision of healthy practices. Now, I would like to conclude that to ensure the optimal health of the persons serving in Bangladesh Army, and especially to reduce the fatality caused by heart disease, efforts to be taken to increase the health awareness by holistic approach in coordination with the civil health sector. Basic health education, active participation of the electronic and print media have great role in creating awareness and dissemination of knowledge regarding any public health problem. Various stress reducing activities can be introduced in centers to lower the rate of fatal incidents. In this regard, clinical psychologists may be appointed to evaluate the mental state of the trainees, recruits to avoid training-related physical and mental injuries. To prevent heart disease, regular physical exercise and adoption of routine healthy life and avoidance of fatty food may play a vital role, where increased awareness may save the persons prone to develop heart disease. Thank you very much.
Thank you, Dr. Sheikh. That was an excellent presentation. Hope the participants have learned and benefited by sharing your research work. So kindly proceed with the question and answer session for Dr. Sheikh.
Okay.
Najman City from the UAE. This is a collaborative work between our university, my department, and the isolation hospital in the city. It's called Sheikh Khalifa Medical City in Ajman. So this is the content of my presentation. I will give a brief updates about the COVID-19, and then I will move to the study and the outcomes of my studies. As you know, guys, the COVID-19, it's declared a pandemic, global pandemic, and it's caused by the SARS-CoV-2 viruses. And this pandemic started and detected in December 2019, and it was declared a global pandemic by the WHO in March 11th, 2020. And after around 3 years of the pandemic, the WHO ended the global public health emergency, and this was in May 5th, 2023. This is a summary of the global dashboard of what was going on in the globe during the COVID-19. As you can see, my colleagues, that more than 700 million cases confirmed globally infected with the COVID-19, and more than around 7 million confirmed global death from the infection. I will speak about the most affected continents from the viral infections. Europe was the most affected continent, followed by the Western Pacific, then America, and the least affected continent was Africa. Also, regarding the mortality rate, Americas uh, were the most affected continents, followed by Europe, Southeast Asia, and the least affected continent regarding the mortality from COVID-19 was also Africa. Locally here in the UAE, we have this brief of the summary. Total cases of the infected people here were around 1 million, around 67,000 people were infected with the disease, and the mortality
Dr.
rate.
Rahia, sorry for interrupting. We cannot see your slides moving.
Oh,
It is in the
really?
first slide itself.
Okay. Can you see it now?
Yeah, it's clear now.
Okay. And now? Okay, clear?
Yeah.
Okay. This is the recent figures here locally. Around 1 million and 67,000 were infected with the virus, and the total mortality here were around 2,300 cases, and the rest were recovered fully from the infection. What do we know about the variants? We're still suffering from some variants of COVID-19. As you know, guys, in most or all viruses, they continue changing their genetics, mutated their genetics. And this mutation and the change in most of the cases will not affect the virulence of the viruses. However, the case here in COVID-19 is the opposite. Few mutations and genetic changes might affect the virulence of the viruses. What do I mean by the virulence? I mean the transmissibility, the severity of the disease, and the response of the disease to the available vaccines, medicines, and the diagnostic tools. Let's see the most important variants. The WHO will investigate usually and continuously investigate the new variants of the COVID-19. And if they found any like significant changes in the virulence, they will sorry they will recognize and report these changes as variant of interest, then as variant of concerns. And these are examples of the variants that developed or emerged. We have beta, alpha, delta, omicron variant. And recently,
Sorry, Dr. Muhammad, still your slides are not moving.
okay, so can I use this can you see it now, the
Yeah,
recent slide?
the new EG,
Okay, so I will keep it like that. Recently, the new variant EG.5 variant, it was in last year, 2023. Another variant called Birula variant also developed after the EG.5. And the last one reported like a couple of months ago was the XEC, and this was reported in Europe, especially in Germany, and it was also detected in USA in June 2024. We are concerned, our research team, concerned about the outcomes of the infection. So how severe the outcomes, how the results, the mortality rate from the COVID-19, and what is the relation between the morbidity and the comorbid condition, especially in diabetic patients. So what do we mean by the severe outcomes in COVID-19? We mean the need of the patient, the COVID-19 patient, how far he or she needs to be hospitalized and admitted, and the need for the ICU admission, the need for mechanical ventilation, or the mortality rate. These are the outcomes, the severe outcomes that we are interested. We were interested to make a relation between these severe outcomes and the other factors like socio-demographic factors and the underlying medical conditions, and most importantly, the COVID-19, the diabetes. So regarding the socio-demographic factors that will affect the outcome of COVID-19, most importantly, the age. And the reports and the studies, global studies, confirmed that the age is a very important risk factor regarding the COVID-19 outcomes. As you can see here, the higher risk will be associated with older ages. For example, 25 times the higher risk of mortality can be seen from age 50 until 64. And 340 times higher risk of mortality will be associated with over 85 years old patients. What about the underlying medical condition in the COVID-19 patients? Most importantly, obesity and the diabetes, especially the complicated diabetes, the uncontrolled diabetes, 1.3 like higher risk factor for developing the mortality in these patients. Before starting our studies, we were interested to share some few important questions about the relation between diabetes and the COVID-19 infection and the associated outcomes. Are people with diabetes more likely to contract the infection of COVID-19? The literature said there is no enough data to show that the diabetic patients are at higher risk of getting infection. There is a difference between getting infected and the outcomes of the disease. The second important question is, do the people with diabetes have higher chance of serious complications from COVID-19? Yes, for sure. All the literature confirms that there are many complications and severe outcomes for in diabetic patients when they contract COVID-19, especially if the diabetes or the blood sugar is not under control. The second questions, are the risks different from type 1 than type 2 diabetes? The literature also said it is not a matter of the type of the diabetes, it's a matter of how controlled is the diabetes and the blood sugar. The last questions, does COVID-19 cause diabetes for non-diabetic healthy people? Yes, they found and detected that in some cases, especially for young adults, it was associated with newly diagnosed diabetes. And this was very prevalent in young adults around 18 years old. However, luckily, these newly diagnosed patients, they like returned back to the normal glycemia after the recovery from COVID-19 with around 6 months. So the diabetes in this case was reversible. Let's go directly to my study. As I mentioned, it is a collaborative work between the university and the hospital, the isolation hospital in Ajman city in UAE. So my study already published in International Journal of Environmental Research and the Public Health, and this is a very reputable journal. The site score for this journal is 7.3. And this is the authors, the PI and the co-PI of the study. So why we were interested in this point? Because diabetes in the UAE is one of the challenges, the health challenges. As you know, guys, around the average prevalence of the diabetes worldwide is 10%. However, in the UAE, we have a little bit higher prevalent rate of diabetes, around 12.3, according to the International Diabetes Federation statistic of the 2022. And we found that people with diabetes here in the UAE and associated HbA1c level over than 70%, which means uncontrolled or poorly controlled diabetes, were around 40% likely to catch the infection and suffer from the complication of diabetes of COVID-19. So our hypothesis was there is a great association between the uncontrolled diabetes and the complications, the serious complication of COVID-19. So our objectives of the study was to collect the data, retrospectively collect the data from these COVID-19 patients and to classify or put them in two groups. The first group is the diabetic COVID-19 patient. The second group was the non-diabetic or the normal glycemic group, and to compare the consequences, the mortality rate in both groups, the serious complications like the hospital admissions, ICU admission, the need for invasive respiratory machines, and how long they will stay in the hospital. So we collected data about the social demographics, about the vitals and the associated reported past comorbidities, then data about the total investigations involving the blood tests, all the imaging, and finally data about the diabetes, the history, the management plan for diabetes, and also the current condition of the COVID-19 and the reported outcome in these patients. Let's go to the results. We collected more than around 500 patient reports. However, most of the reports, and some of the reports were incomplete, so we couldn't analyze them. So the full reports that we collected, around 427 patients, 22% of them all of them are COVID-19, 22% are non-diabetic, and the majority, 78%, are diabetic. The diagnosis of the diabetes here in this study was depending on the local guidelines and was done by the collaborating endocrinologist from the hospital. Here to compare the level of controlling the blood sugars in both diabetics and non-diabetics. 99%, as expected in non-diabetics, was normoglycemic. However, in diabetic patient, diabetic group, 75% were normoglycemic and 25% were hyperglycemic in the admission tests. Let's speak about the diabetes-related features in these diabetic patients. Around 2% of the diabetic participants were type 1 and 98% was type 2, were type 2. 20% of them were taking insulin for controlling the diabetes. Around 15% were taking injectable GLP-1 agonist. 37% were taking oral anti-diabetic agents. 10% were suffering from nephropathy, 10% suffering from neuropathies. Let's go to the analysis of the data that we got from the records. Regarding the social demographics and the comorbidities, the past comorbidities, the average age of the patient, of the 430 patients, was 55, around the average, 55 years old. 70% of them were males, 30% females. Some of them expatriates, some are local Emirati. Employment rate, most of the non-diabetic were employed. However, most of the diabetic were unemployed, and the difference between them was significant. Regarding the body mass index, the average of the population was around 30. So they are between the overweight and the obesity level 1. And it was very similar, diabetic and non-diabetic. The smoking, surprisingly, most of them were non-smoker in both diabetic and non-diabetics. About the cardiovascular diseases, there was a significant difference between both of them. For sure, the diabetic were higher in the cardiovascular diseases, higher in the dyslipidemia, in the hypertension, and in other comorbidities. And the difference between two groups were very significant. Regarding the clinical features and the laboratory parameters finding of the patients at the time of the admissions. As normal, patient of COVID-19 suffer from cough, fever, chest pain. However, regarding the myalgia, vomiting, and diarrhea, it was very clear in the diabetic, and the difference between them and non-diabetic was very significant. The other vital signs, respiratory rate, and the systemic diastolic blood pressures, the level of the oxygen, peripheral oxygen here was significant, but all of the participants, most of them, more than 95% was normal in the oxygen, peripheral oxygen. The other laboratory finding regarding the blood glucose, it was very significantly different, very high in the diabetic than in the non-diabetic group. And one interesting parameter here is the procalcitonin, which is one of the inflammatory markers. It was higher in the diabetic than in non-diabetic, and the difference was significant. Let's go to the important parameters. The rate of mortality between the two groups, the duration of the hospitalization, and how frequent they needed the ICU admission, and how frequent they needed the mechanical ventilation. These are the important parts in the study. As you can see here, regarding the in-hospital duration, the mean duration in diabetic was higher in diabetic than in the non-diabetic, and this was expected. What about the ICU admission and the mechanical ventilation and the total in-hospital mortality? Also, as you can see, the orange bar here is for the diabetic. It was higher regarding the need for ICU admission, and almost there were no need for the mechanical ventilation in non-diabetic. However, more than 20% of the diabetic needed mechanical ventilation. The rate of the mortality here in the diabetic were around 20%. However, it was less than 10% in non-diabetic. The mortality and relating this mortality with the other social demographic and clinical features, we detected and we found that the age was the highest factor regarding the mortality. rate in the patient, including diabetic and non-diabetic. Also, the mortality was related to the ICU. Whenever they needed ICU admission, the rate of the mortality increased. So let's conclude the results of our study. In the diabetic patient found to be at significant higher risk for the need of mechanical ventilation, the need for the ICU admissions, and also the diabetic patients found to be at significantly higher risk of length of hospital stay compared with the non-diabetic patients. However, using the multiple regression analysis reveals that diabetes may be a significant risk factor for the that we mentioned, the need for mechanical ventilation, the longer hospital stay, but not a factor for the ICU admission or a factor for the mortality. So our study shows that while the association between diabetes and mortality didn't reach a statistical significance, the point estimate of the odds ratio suggests that a potential increase in risk of mortality that was doubled in diabetic patients than in non-diabetic. This will suggest to do future studies analysis of the data from this COVID-19 patient to confirm this finding. However, we recommend this association between the diabetes and the morbidity highlight importance of the early detection management in diabetes and the priority for updated vaccination, also to prevent any complication and to improve the overall health outcome in this sector of patients. And this was the conclusion of my study. This was my references. And we need to acknowledge and thank all the sponsors for this study, all the research team, also all the hospital staff members and the students who participated in my studies. And this also my team of the study. I would like to thank you all and thank you so much for your listening. Any questions?
Thank you, Dr. Mohammed. That was a very excellent presentation. Hope the participants have learned and benefited by sharing your research work. Kindly proceed with the question and answer session for Dr. Mohammed.